화면 공유 테스트 안 해봐도 되겠죠?
어, 지금 해보는 게
잘
좋을 것
되겠지?
같아요.
해볼까요?
일단은 이민정 교수님부터 해보시는 게 좋을 것
아,
같습니다.
그럴까요? 네,
네,
잠시만요. 제가,
순서대로. 네.
네,
지금 아직 노승수 교수님이 안 들어오신 거죠?
참가자 화면 공유가 비활성화되어 있습니다.
아, 그러면 이거는 저기 어드미니스트레이터한테 부탁해야 되는 거죠?
그 질문 들어오는 채팅창 같은 게 있나요?
없습니다.
그럼 우리끼리만 질문하고 우리끼리만 하는 거예요?
유튜브나 저쪽으로는 네, 스트리밍 되고 있는데요. 그쪽에서 될지는 모르지만 이쪽으로 넘어오진 않습니다. 노승수 교수님 연락처 아시는 분 계신가요? 들어오시겠죠?
시간이 혼자는 있을지도 몰라서 확인해보는 게 좋을 것 같아요. 시차가 있어가지고.
노승수 교수님 연락처 아시는 분 계신가요? 혹시 혹시 차병원에 아시는 분 있으신가요? 연락처 지금 유혜린
제가,
선생님께 여쭤봐야 되나?
네. 제가 농내장 쪽에 한번 물어볼게요.
네. 저 파일 액티베이션 되는지 한번 파일 화면 공유 되는지 한번 김윤전 교수님 한번
네, 잠시만요.
예.
근데 아직도 공유가 비활성화돼 있어서 지금 공유를 할 수가 없습니다.
들어오셨네요. 안녕하세요, 교수님. 그 배경을 요 IOC 그 AIOS IOC 파일 배경으로 바꿔주실 수 있을까요, 교수님? 이민정 교수님 한번 공유 눌러보세요. 되는 것 같습니다.
아, 네.
먼저 띄워놓으셔도 좋을 것 같습니다.
공유하면 될 것 같아요. 네. 지금
네.
띄우기는 좀, 네. 이따
네네.
하겠습니다. 네. 제가 첫 번째죠? 네.
Hello. This is from backend team. The permission has been given to you already. Can you try sharing the presentation again?
Okay. 이민정 교수님 쉐어링 해봐달라고 테스트 해달라고 말씀하시니까 한번 쉐어링 해봐 주시면 좋을 것 같습니다. Thank you for sharing. It works well.
Yeah, good evening, everyone.
Hello, Dr. Bala.
Hello, ma'am. Really lovely seeing you. So we are, I think, another 1 or 2 minutes before we start this session of Korean Ophthalmological Society, ma'am. Welcome you all to this AIOC International Conclave. So I think we have with us Professor Wong Kyung Cho, who's the chairperson. Co-chairperson is Professor Kyung Jin Cho. Dr. Kamaljeet Singh is the convener, and my co-moderator, Dr. Krishna Prasad Kudlu, is going to join shortly. So we have excellent line of panelists also lined up. We have Professor To Im Kim, Dr. Sahil Agarwal, Dr. Devang Angmo, Dr. Devesh Kumawat, Professor Praful Maharana, and Dr. Sridevi Nair from RP Center, All India Institute of Medical Sciences. And we have excellent line of speakers lined up. Professor Ming Jong Lee, Professor Seong Soo Ro, Professor Yoon Jeon Kim, Professor Yeji Moon, Professor Kyung Woo Kim, Dr. Krishna Prasad Kudlu, and Dr. Amit Purwal. So if the chairpersons allow, I think we can, are all the speakers there? Professor Min Jong Lee is there?
Yes, she is here.
Okay.
Good evening, everyone. This
All,
is
and
Dr.
I think
Prafulla from
if
RP
it's,
Center.
yeah,
Sorry, my
Dr.
video is not
Prafulla.
working. Good evening, Dr. Bala, sir.
Yeah, link is not working.
My video is not working. I don't know why.
Okay, can the IT person just look into it?
I think, sir, you can start the session.
I think we can
It's
start
already
the
6.
session since it's already time. So we'll start with the first talk of Professor Min Jong Lee. And she's going to talk on diffuse lacrimal gland enlargement, diagnostic considerations, and treatment. So you can share the screen, Professor Lee.
Okay, thank you for a nice introduction. I'm
Yeah.
very happy to participate in this wonderful joint symposium between two national ophthalmology society. I will share my screen and play my video.
Yeah, we can see your slide, ma'am.
How?
The audio is
Dr. Lee, we cannot hear your sound.
Yeah, we cannot hear
Really?
you. Yeah, we cannot hear you.
Let me check. Good evening, everyone. The title of my talk today is Diffuse lacrimal gland enlargement, diagnostic considerations, and treatment.
Can you increase the volume of sound, ma'am?
To start with the anatomy of the lacrimal gland. The lacrimal gland is an exocrine gland located in the superior quadrant of the orbit. The lacrimal gland is a bilobed structure composed of the orbital and palpebral lobes. The lateral horn of the levator aponeurosis divides the gland into lobes. Lacrimal excretory ductles drain the tear and open into the superior conjunctiva fornix. Because the ductles pass through the palpebral lobe, excision of the palpebral lobe can disrupt the tear secretion and cause significant ocular surface problem. So, lacrimal gland biopsy is preferentially performed on the orbital lobe. Common presenting signs of the lacrimal gland disorders include upper eyelid swelling, palpebral mass, proptosis, and temporatosis. Inflammatory signs like periocular pain or tenderness, eyelid erythema, conjunctival injection, and chemosis can be seen according to the diagnosis. Many different types of tumors can occur in the lacrimal gland. Tumors of the lacrimal gland can be divided into epithelial and non-epithelial lesions. Common benign epithelial tumors include pleomorphic adenoma and lacrimal ductal cysts. Malignant epithelial tumors include adenoidosis carcinoma, pleomorphic adenocarcinoma, and de novo adenocarcinoma. Benign non-epithelial tumors are mostly dacryoadenoides. The most common non-epithelial lacrimal gland malignancy is lymphoma. In this presentation, I will focus on non-epithelial lacrimal gland tumors, which usually present as diffuse lacrimal gland enlargement. Dacryoadenoides refers to an inflammation of the lacrimal gland. The lacrimal gland normally contains mucosa-associated lymphoid tissue, IgA positive plasma cells, and a few T and B lymphocytes. So the lacrimal gland can be a primary target of the immune system and an exaggerated immune response can occur. Although infectious dacryoadenitis can occur, dacryoadenitis is mostly of non-infectious origin. Non-infectious dacryoadenitis can be classified into idiopathic orbital inflammation and specific autoimmune dacryoadenitis. The IgG4-related disease is a common cause of autoimmune dacryoadenitis, and sarcoidosis, GPA, and Sjogren's syndrome also can cause dacryoadenitis. The clinical onset of idiopathic dacryoadenitis usually acute or subacute. The typical symptoms are eyelid swelling, tenderness, and S-shaped deformity. On palpation, a firm mass can be felt in superior-temporal orbit. Limited abduction or supraduction may be present. There may be also conjunctival injection or chemosis. On imaging, diffuse enlargement of lacrimal gland with homogeneous enhancement is characteristic. It can also involve adjacent orbital fat or sclera, and the gland shape is usually preserved. The diagnosis of idiopathic dacryoadenitis can be made after excluding specific causes. Besides basic blood labs, individualized serological tests are advisable based on clinical and radiologic findings. Lacrimal gland biopsy should be actively performed to confirm tissue histopathology. The mainstay of the treatment is oral steroid and intralesional steroid injection, surgical debulking, immune modulating agent, and radiation treatment can be utilized as primary or secondary treatment. IgG4-related disease is a systematic fibroinflammatory condition characterized by IgG4 positive plasma cell infiltration. Dacryoadenitis is the most common manifestation of IgG4-related ophthalmic disease. IgG4-related dacryoadenitis typically presents as chronic and palest swelling with palpable lacrimal glands. Bilateral involvement is common. Multiple organ involvement, including the parotid gland and salivary gland, can be seen. Orbital imaging shows characteristically a diffuse enlargement of the bilateral lacrimal glands, enlargement of extraocular muscles, and trigeminal nerve branches also can be seen. IgG4-related dacryoadenitis can be diagnosed when the comprehensive diagnostic criteria for definite or probable IgG4-related disease were satisfied. The comprehensive diagnostic criteria included clinical or radiological evidence of organ involvement, elevated serum IgG4 concentration, and abundant IgG4 positive plasma cell infiltration. Lacrimal gland lymphoma accounts for 1/3 of oculogenic cell lymphoma, and extranodal marginal zone lymphoma is the most frequent subtype, up to 90% in Korea. Lacrimal gland lymphoma primarily affect elderly patients and a predominance of females. Clinical features of the lacrimal gland lymphoma are mainly related to the mass effect of the tumor. On imaging, lacrimal gland lymphoma is seen as a homogeneous enlargement of the lacrimal gland without invasion of adjacent tissue. Signal intensity is usually isodense relatively to extraocular muscle. Radiation with a dose of 20 to 30 gray is the treatment of choice for patients with oculogenic cell lymphoma. Although excellent outcomes have been reported, radiation treatment has a potential risk of distant recurrence and ophthalmic toxicities. So, other modalities like chemotherapy, immunotherapy, and less invasive treatments can be considered as an alternative treatment option. Then, how can we make differential diagnosis of non-epithelial tumors of the lacrimal gland? I'd like to share a recent paper about comparative analysis of clinical and radiological features among dacryoadenitis, IgG4-related disease, and lacrimal gland lymphoma. The mean age of the patients with lacrimal gland lymphoma was significantly older than dacryoadenitis or IgG4-related disease. Bilateral disease was more common in dacryoadenitis and IgG4-related disease than lymphoma. On imaging, the IgG4 and lymphoma groups showed larger lacrimal gland size and more common wedge sign than dacryoadenitis group. The IgG4-related disease group showed more frequent involvement of the extraorbital structures, including infraorbital nerve, salivary gland, and paranasal sinus. However, the signal intensity and enhancement pattern were not significantly different among three groups. So, biopsy is frequently needed to make definite diagnosis in patients with diffuse lacrimal gland enlargement. Lacrimal gland biopsy can be performed through eyelid crit incision or subbrow incision. I'd like to show some cases. A 64-year-old male visited my clinic complaining of both upper eyelid swelling for 3 months. Lacrimal glands were well palpable in both eyes, and abduction limitation was noted. CT scan showed lacrimal gland enlargement in both eyes. I did a lacrimal gland biopsy, and the pathology report was chronic inflammation with fibrosis. With an impression of dacryoadenitis, oral steroid was prescribed and the response was good. However, 2 years later, eyelid swelling and lacrimal gland enlargement recurred. He also complained of abdominal distension and discomfort. On abdominal CT scans, diffuse pancreatic swelling was shown. Serum IgG4 level was also elevated. The final diagnosis of IgG4-related disease was made after repetitive lacrimal gland biopsy. A 48-year-old female visited my clinic complaining of upper eyelid swelling and pain of the right side for 3 months. On CT imaging, diffuse lacrimal gland enlargement with mild enhancement was shown. Under the impression of dacryoadenitis, steroid treatment was tried, but the efficacy of the treatment was not clear, partly because of the poor compliance. So I decided to do surgical biopsy, and the final diagnosis was lymphoma. In summary, lacrimal gland tumors constitute a wide spectrum of different entities. Common pathologies of non-epithelial tumors include idiopathic dacryoadenitis, autoimmune dacryoadenitis, and lacrimal gland lymphoma. Careful physical examination, laboratory tests, and radiologic evaluation are mandatory, and surgical biopsy is often needed for definite diagnosis in many cases. Thank you for your attention.
Thank you for the presentation, Dr. Lee. It was very informative and very interesting lecture and interesting cases as well. I have a question. When you do the biopsy for the lacrimal gland, do you prefer subbrow incision or the lead crease incision?
First of all, I'm sorry for the audio problem. Is it okay now?
Yes.
Yeah, we can hear you.
Okay. Thank you for the good question, Dr. Zhou. That is a clinically very important question. And I think the eyelid crit incision is the best way to hide the surgical scar. And I always consider lead crit incision first for the lacrimal gland biopsy. However, subbrow incision is also very helpful for some patients, especially when the patient has no eyelid crease, or the lacrimal gland enlargement is mainly posterior part, and we can assess more directly to the posterior part of the lacrimal gland using the cerebral incision. So I generally use the eyelid crease incision in 80% to 80% of my patients, and cerebral incision for the other 20% of the patients.
Thank you.
And what is the indication of biopsy? Is it recurrent lacrimal gland swelling, basic thing is, or when do you think, or it's a chronic swelling? So what do you think is the indication for taking biopsy in these cases?
Yeah, as I said, the common etiologies of diffuse enlargement of the lacrimal gland are idiopathic keratinizis, IG-related disease, and lymphoma. And I think, and those diseases can be definitely diagnosed through only pathological report. So when I started my career 15 years ago, I used to use steroid frequently, but nowadays I more actively perform lacrimal gland biopsy.
So even before starting steroids, would you like, or you give a short course of steroid for some time, and if it's not resolved,
if the inflammatory sign is definite, I use steroid first, but the swelling is chronic and the disease duration is long, I usually prefer biopsy before the use of the steroid.
Okay. Thank you so much. I think it was really a very illustrative talk. Thank you so much for your talk. Now, can we come to the next speaker? Next speaker is Professor Seung-Soo Roh, and he's going to talk on mixed era or mixed era. All yours, Professor Roh.
Okay, thank you. Thank you for the introduction. I'm gonna share my slide.
Yes, sir. You can go on to the share screen on the bottom, that green rectangle, and then.
In the meantime, sir, I would like to ask something to Dr. Lee.
Yeah, Doctor.
Thank you, Lee. That was an excellent talk. See, I'm a corneal surgeon. So my point is, do you find all this lacrimal gland biopsy patient, do they develop some sort of dry eye in future?
For the incisional biopsy of lacrimal gland, it doesn't induce dry eye. Even sometimes I do lacrimal gland excision for the especially epithelial tumor of the lacrimal gland. It can cause dry eye, but it is not common because there are many accessory glands throughout the conjunctiva. So yeah.
Thank you.
Well, I think
So,
we have to talk to Professor Roh.
Yes, thank you.
Yes.
Thank you, Chairman. Thanks for having me here at this wonderful joint symposium. It's a fancy meeting, and all the topic seems very interesting. My talk today is about mix. I think we're living in the world of mix, the minimally invasive glaucoma surgery, but to be more precise, it is more like a world of mixture of traditional glaucoma surgeries and new glaucoma devices. Now we are seeing the competition between electric vehicles and gas vehicles. We know the proportion of the electric vehicles will definitely grow in the future, but for someone, it is hard to make a decision because still gas vehicles are easier and faster to fuel, and the initial cost is lower than electric vehicles. And that's the reason why people are considering to buy a hybrid vehicle as a side menu. I think it goes very similar to when we decide which surgical option you should take in the world of glaucoma as well. According to a report from the United States, the proportion of cases that two different mixed surgeries in the US done on the same day was higher than 36%. And the most common combination was ECP and iStent. And moreover, when it comes to sequential surgery, more than 63% of the patients who have received glaucoma surgery underwent multiple procedures on subsequent days within 6 years, but still only 4.4% underwent a mixed procedure after trap or glaucoma drainage device placement. So considering that it has been a while, like more than 10 years, mixed procedures have come to our real practice, I think it is fair to say we can tell at least the world is already in the era of mixed glaucoma procedures rather than in the era of mixed procedure. And now we now have more options to treat our glaucoma patients than ever before. But the problem is we also feel that there is a quite huge discrepancy between what the paper says and what we get from our real practice. To tackle this issue, we have to make clear what mix really is. So what is mix? If you look at this diagram, the American Glaucoma Society seems to think mix is a glaucoma procedure that does not disrupt the normal conjunctival structure. We can see this from how they have classified the black forming implants such as ab internal Zen as a mixed procedure, whereas ab external Zen or PreserFlow as a traditional glaucoma filtering surgery. I think it is fairly reasonable thinking when you have to care more about the tissue damage and the feasibility to provide a second or additional procedure on the same surgical area. On the other hand, Europeans seem to have a very conservative view on the term minimally invasive, since the recent EJS guideline indicates that only the ab internal non-black forming procedures can be defined as mixed, such as iStent, ECP, or Kahoot blade. And so why is mixed? In my view, the biggest significance of mix in this era is to consider this fundamental question. Can you go back to the time point before you make the decision, like in the movie Avengers Endgame? If you think about the exit strategy, if you have done a trap first to your patient, the additional option would be a second trap or an armored glaucoma valve implantation. However, you have done a mixed procedure first, you have more chance to do an additional procedure with mixed technique like second mix or third mix, even on the same surgical area, in my opinion. And the trap or armored valve implantation can be delayed without further progression if you can choose the right patient. This is very important considering patient's lifetime, because second trap in his or her 50s could be detrimental compared to second or third mix in the patient's 60s, and consider the conventional glaucoma surgeries as the next option. I think this is the biggest importance of mixed procedure, that it has wider exit strategy than conventional glaucoma surgeries. You can check out more about this issue from the recent podcasts summarized in the AIO updates. And so where are we right now with mix? How effective they are? In South Korea, we have only one mix which can be classified as non-black forming mix, the iStent. iStent is a trabecular bypass device, so it is supposed to be implanted in primary open-angle glaucoma, which is medically uncontrollable. However, in theory, steroid-induced glaucoma or uveitic glaucoma cases that have blocked the trabecular mesh outflow could be suitable for the iStent procedure to some patients. The effect is very clear. You can expect mild to moderate degree of eye lowering effect with smaller need for glaucoma medication after the surgery. If you see this meta-analysis paper, you can find the phaco iStent procedure is slightly more effective than the phaco alone procedure by lowering IP of 5 mmHg after 6 months on average. Apart from the pressure level, the phaco iStent procedure can decrease the number of eye drops by approximately 0.5 eye drops in average. According to my data as well, a similar result was shown. IP was lowered by 3 mmHg with 1 eye drop discontinued in average 6 months after phaco iStent. Let's move on to the black forming mix. We have only Zen, but no PreserFlow yet as a black forming mix in South Korea. It has a very similar outflow dynamics to glaucoma drainage devices, but it makes a subconjunctival bleb just like the trap. So it is easily misunderstood as a easier version of trabeculectomy. However, it is very dangerous if you see Zen in that way. It forms a bleb, but through very thin tube, whereas the trap bleb is maintained by multiple incision of outflow pathways from the sclera. So the Zen bleb is very vulnerable to the factor that can occlude the stent lumen from the inside or bleb changes from the outside, such as bleb fibrosis. And this difference, which you might not get it before you have it, could makes you very embarrassing and you can get disappointed by the result. But if you do the Zen properly, you can get very powerful IP lowering effect with very small need for eye drops. And also, the properly performed Zen can allow you the feasibility of doing second implantation in the same surgical area. This is one thing that I like to highlight today, which is one of the very important advantages in mixed procedure compared to conventional glaucoma surgery procedures. Normally, standalone Zen gel stent implantation can lower the IP down to 9 mmHg on the first day, then can maintain the IP around mid-teen until 2 years. And additional glaucoma surgery was needed in almost 13% of the patients within the 2 years follow. This group, which has followed their patients for more than 4 years, reported that the IPS maintained around 14 mmHg until post-operative 4 years, and additional glaucoma surgery was needed in 24% of their subjects. Fortunately, I have the longest follow-up data of Zangel stent in South Korea, and according to the data, IP was maintained around 15 mmHg with using less than a single eye drop. However, the additional surgery was needed in 19% of the subjects within 2 years. I believe three biggest differences of Zen procedure compared to the traditional glaucoma surgeries are the target patients, the open-end glaucoma, and the target pressure, which should be mid to high teen, and the target duration. In my data, the average time took to additional operation was almost 500 days in average. So some patients we cannot expect a good result longer than several years. If you are 100% ready for the procedure, the RP should be lower than 9 on the first day. If it's not, it means you are already failing. This is because the peritubular flow induced by the injector needle, so hypotony would be very common, and you have to be prepared for the intracameral OVD injection on the first week. And I hope you can remember that normally cohesive OVD is needed, not dispersive OVD as the manufacturer has recommended in the early days. This is my management plan. You can wait and see only if the IP is lower than 7 and the chamber is deep. And if you have shallow chamber, you need to use the atropine eye drop with or without chamber reformation with cohesive OVD. And if the IP is higher than 9, something on your skill needs rechecking. And this is my rubric for the Zen procedure. You can check by posting the video clip later. The last slide. We are living in a world of mixed glaucoma procedures. iStent can offer a sustainable IP control, and early IP after Zen should be in 1-digit figure. Thanks for your attention.
Thank you for a wonderful presentation. I have one question. Why do you think the Zen stent is less popular in some countries than expected?
That is an excellent question. We know there are different situations in each country, like healthcare systems, referral systems, or reimbursement, that could lead the discrepancy between what the paper said and what the surgeons have really experienced. But the most important reason why the Zen is less popular in some countries is the lack of understanding the glaucoma surgeons themselves by the manufacturer or the distributors. When you launch a novel device in the market, the education and training is the key. Especially like the Zen, it is a conceptually very sensational device, I think. And like I said, it could be easily misunderstood as an easier version of trabeculectomy, which is really, really wrong. And this could have led to the quick disappointment by the users in the early days. And I believe the recent issue on the app external Zen technique, which is very getting popular, is a part of this issue. And in some countries like South Korea, there are only 2 surgeons, including me, who had the chance to meet the Zen instructor in their first cases.
Thank you.
I think that's very nice, sir. So of the Zen and iStent, I think what I have understood from your presentation is you prefer using Zen implant compared to the iStent, sir?
Yeah, if you only see the pressure level, maybe Zen is more powerful. But in my clinic, there are more like wider indication for the iStent procedure, because we have more like around 20 millimercury level who has the eye drops, like 3 eye drops in their home. And it's very for me to have a very disappointed was that someone who are familiar with the glaucoma surgeries like trabeculectomy prefers to do Zen, not iStent. But I think iStent is more effective in the whole market, and that can prevent, like I said, the time point, delay the time point to meet the trabeculectomy or glaucoma drainage device. If you do the iStent, when you see the patient has a cataract and he or she has a glaucoma, and you can do the iStent first. So I think 2 different approaches and 2 different markets are there in the glaucoma area, I think.
Okay. Any other comment from any other panelist? Dr. Praful, you have any comment? Dr. Cho?
I'm good.
Okay, okay. So I think that was again a very nice presentation. So we really very nicely explained both the implants, the iStent also, and the Zen, and the results, and your protocol of using and both the implants, and how do you manage these cases. I think very excellent talk, sir. Thank you. So
Thank
we
you.
move on to the next talk by Professor Yoon Jeon Kim, and she's going to deliver a talk on genetic testing in inherited retinal dystrophy. Yeah. Okay, ma'am, you can start your presentation.
Thank you for the kind introduction, and thank you for having me here in this wonderful joint symposium. I do like to share my video.
Good afternoon, everyone. My name is Yoon Kim from Assam Medical Center. I would like to thank the organizing committee for having me here in this wonderful symposium. Today, I would like to talk about genetic testing in inherited retinal dystrophy. Current AAO and European guidelines recommend genetic testing for all patients with IRDs. However, it is not simple because of the diversity and complexity of IRD genetics. As next-generation sequencing (NGS) has developed, sequences for multiple target genes can be read simultaneously, and this offers more effective methods for the molecular analysis of multigenetic disorders such as IRDs. In our center, we have a virtual panel which is consisted of 595 genes associated with ocular function and development. According to the phenotype, IRD patients were grouped as RP, cone rod macular dystrophy, LCA, and vitreal retinopathy, and selected genes were primarily interpreted. These are the results of genetic analysis conducted on patients with a phenotype of RP. A total of 279 proband subjects were included, and we were able to identify the causative gene in about 60% of cases. And in order of frequency, the causative genes were EYS, USHA2A, and PD6B. Genetic testing in IRDs can have the following benefits. First, disease course and prognosis can be predicted through genotype and phenotype correlation, which can help patients plan and manage their lives. Based on our database, we analyzed the clinical manifestations of major RP causative genes. These are the fundus, autofluorescence, OCT, and visual field testing results according to the aging of patients with EYS mutation. You can see coarse pigmentation, which is mainly observed in autosomal dominant inheritance pattern, progress with aging around the major vascular arcade in this autosomal recessive inheritance gene. In the patients with the PD6B variants, significant degeneration can be found at a rather young age, and cystoid macular edema was frequently observed in about 50% of patients. And 3/4 of patients with USHA2A variants have vitreomacular abnormality. Within the group of patients with variants of RP1, clinical features were different according to the inheritance pattern. In patients with autosomal dominant mode of inheritance, progressive pigment aggregation with aging was found. Meanwhile, in patients carrying autosomal recessive mode of inheritance, macular atrophy was prominent. The causative gene was significantly different according to the age which symptoms first appeared. In the case of the first symptoms before the teens, PD6B was the most common gene. And in the case of the first symptom after the 40s, USHA2A was the most common gene. And in other cases, the EYS gene mutation was mostly seen. In addition, when comparing the progression rate according to the follow-up period, in terms of functional visual acuity loss, patients with PD6B variant showed a faster BCVA reduction rate. Meanwhile, in terms of structural progression, degeneration progressed rapidly in the USHA2A group. Second, we can confirm the phenotype-based clinical diagnosis using the genotypes. In 15% of patients, genetic testing changes the phenotype-based misdiagnosis and provides accurate information to patients. This can also help better disease management, including other systemic conditions, and understanding the risk for family members for IRD. If you see these patients in the clinic, RP would be one of the most probable diagnoses. Actually, we originally diagnosed these patients as RP. However, the results for the RP panel was negative, and the final genotype-based diagnosis were changed through whole exome sequencing. The first case was an asymptomatic 24-year-old female revealed to have retinal changes associated with pseudoxanthoma elasticum due to ABCC6 mutation. This 17-year-old male with night blindness was diagnosed with choroideremia after genetic testing. This 45 male patient was diagnosed with X-linked juvenile retinoschisis. Like this case, it is difficult to identify typical characteristics in advanced stage of degeneration, so genetic testing can help to make an accurate diagnosis in these cases. And this 52-year-old female patient was diagnosed with BAT crystalline retinopathy after genetic testing. This last case, a 22-year-old female patient who underwent kidney transplantation was diagnosed with senior Lincoln syndrome after genetic testing. Senior Lincoln syndrome is a kind of ciliopathy which mainly affect eye and kidney. So after the genetic testing, we can tell the cause of renal dysfunction as well as ocular problem. And finally, one of the most important things in genetic testing for IRD is to determine the eligibility of potential therapeutics such as gene therapy and not to miss the treatment opportunity. And it can provide the natural history as the reference for control group in gene therapy. And it can be applied for developing the animal models and the novel therapeutics. The eye has many properties that are good for applying gene therapy. It is an immune-privileged organ and has an easy surgical approach and good evaluation tool for subsequent anatomical evaluation. And by acting on a post-meiotic cell through the subretinal space, therapeutic levels can be achieved with a small amount of factor. Based on these advantages, Luxturna is the first gene therapy approved by the FDA. These are many other gene therapy clinical trials currently being conducted, and we ophthalmologists have an obligation to screen the patient whether he is eligible for gene therapy before his disease is too advanced. To summarize, due to the diverse molecular genetics of IRD, genetic testing is essential for accurate diagnosis. Based on genetic diagnosis, we can predict disease course and prognosis and determine potential candidates for gene therapy. In addition, these results are the basis for developing and evaluating the efficacy of future therapeutics. Thank you for your attention.
Sorry. That was a really wonderful talk on the genetic testing in inherited retinal dystrophy, because you rightly pointed out that by finding the genotype-phenotype correlation, it also helps us in confirming the phenotype-based diagnosis and finding eligibility for potential therapeutics and also gene therapy. I think exciting thing are in store once we have the gene therapy for these inherited retinal dystrophies. And main thing is we can also counsel the parents about whether they should go for future pregnancies or not. And we can also find the other family members can be examined to really diagnose the disease. Very nice talk, ma'am. Thank you so much.
Thank you.
Any comments from the panelists? So I think we can move on to the next talk. And the next talk is by Professor Yeji Moon, and she is going to talk on pediatric optic neuritis. How is it different from adult optic neuritis? Professor Moon, ma'am. Professor Moon is there? Yeah.
Thank you for this introductions. I will share my video. Hello everyone, I'm Yeji Moon from Asa Medical Center of Korea.
Thank you for having me as a speaker. Today, I'm going to talk about pediatric optic neuritis, and I'll be focusing on how it differs from adult optic neuritis. One thing that I want to address before I start is that children are not little adults. Therefore, optic neuritis in children has several characteristics that differ from optic neuritis in adults. I'd like to visit some facts that we have already run about pediatric optic neuritis. First, the incidence of pediatric optic neuritis is lower than that of adults. According to a national population-based study in Korea, approximately 1 out of 100,000 children has optic neuritis every year, which is only one-third of the incidence rate in adults. In prepubertal patients, there is an equal incidence in boys and girls, in contrast to the higher female predominance in postpubertal children and adults. Bilateral optic neuritis is more common and it is associated with younger ages. Also, optic disc swelling is more commonly observed in pediatric optic neuritis, as it occurs in over half of cases. In contrast, pain with eye movement is less frequent in pediatric patients, whereas the symptom is a typical feature in adults. Vision loss is more pronounced in pediatric optic neuritis, with more than 50% of children presenting with visual acuity poor than 20 to 100. However, visual outcome is better in children, with about 80% of patients regaining visual acuity of 20/20 a year after optic neuritis. We have covered the general characteristics of pediatric optic neuritis, but we should note that optic neuritis is not a specific disease. Optic neuritis describes any condition that causes inflammation of the optic nerve. Although optic neuritis can occur as an isolated condition without any other manifestation, it may represent a sentinel attack or relapse of CNS demyelinating disorder. So, from now on, let me go over the characteristics of each subtype of optic neuritis: multiple sclerosis optic neuritis, aquaporin optic neuritis, and Moog optic neuritis. Multiple sclerosis is a well-known CNS demyelinating disease associated with optic neuritis. However, the precise immune-mediated pathophysiology remains uncertain, and disease-specific autoantibodies have not been identified. In children, as in adults, multiple sclerosis is diagnosed according to the McDonald criteria. It has been reported that pediatric onset multiple sclerosis is associated with higher relapse rates when compared with adults. Therefore, predicting progression from optic neuritis to multiple sclerosis is important, but it remains challenging. Fortunately, the risk of multiple sclerosis after initial presentation with optic neuritis is lower in children than in adults. The risk factor for conversion to multiple sclerosis are old age, abnormality on brain or spinal MRI, presence of oligoclonal bands at initial presentation. Let me go over a case of a 6-year-old boy who came into our clinic with bilateral visual disturbance. At initial presentation, his optic disc looked normal. Here we have the MR images, and both optic nerves showed enhancement without any other abnormalities in brain. The test for oligoclonal band in CSF came back negative. But 2 months later, he had dysarthria and brain MR image shows multiple lesions with increased T2 signal intensity. His vision improved to normal range despite optic atrophy. He was only 6-year-old and brain MRI at initial presentation was normal, so he was at low risk for multiple sclerosis, but he experienced a relapse and he was eventually diagnosed with multiple sclerosis. So I would like to emphasize that a careful and multidisciplinary approach is essential for pediatric optic neuritis patients. Here is the second subtype of optic neuritis, which is aquaporin optic neuritis. There is growing evidence that aquaporin 4 antibody causes direct astrocytopathy and urinary necrosis with secondary oligodendrocyte loss and demyelination. Neuromyelitis optica spectrum disorder, NMOSD, is a CNS inflammatory disease related to aquaporin 4 antibodies. Optic neuritis and transverse myelitis are the main clinical phenotypes. Pediatric onset NMOSD is relatively rare, as only less than 5% of NMOSD seropositive cases had pediatric onset. But clinical, neuroimaging, and laboratory characteristics of pediatric NMOSD are similar to those of adult onset disease, such as poor visual recovery, pronounced RNA thinning, enhancement of the posterior optic nerve, optic chiasm, or optic tract, lesion extension beyond half of the optic nerve length, the relapsing clinical course. Therefore, diagnostic criteria for adults are utilizable in pediatric patients. However, some differences can be found in terms of epidemiology. It is relatively rare in children, especially before age 11. It has been suggested that pediatric NMOSD may have lower female preponderance. Although the incidence of aquaporin 4 optic neuritis in pediatric patients is lower than in adults, clinicians should be aware of the higher recurrence rate in aquaporin 4 positive patients because the accumulation of disability is largely attack-related. Now, let's move on to myelin oligodendrocyte glycoprotein MOG antibody. Unlike aquaporin 4 antibody-mediated astrocytopathy, MOG antibody is thought to cause inflammation and myelin destruction without direct astrocyte injury. This mechanism may explain the less severe courses of MOG antibody-associated disease, MOGAD, in comparison to aquaporin 4 NMOSD. MOGAD encompasses a broad spectrum of clinical phenotype. The clinical phenotype changes with age, from encephalitis-like phenotype to opticospinal phenotypes, including optic neuritis and myelitis. It suggests that regional expression of MOG is age-dependent. However, it should be noted that MOG optic neuritis is account for a large proportion of pediatric optic neuritis. The clinical feature of MOG optic neuritis closely resemble the characteristic of typical pediatric optic neuritis, such as prodromal illness, bilateral optic nerve involvement, optic disc swelling, and better visual recovery. This proves that MOG optic neuritis has a large proportion among all pediatric optic neuritis. In a mixed cohort with children and adults, pain and perineural enhancement on MRI is reported to be a characteristic findings of MOG optic neuritis. But according to another study, they are relatively less frequent in children, so it should be reminded that age-dependent clinical characteristics may appear in MOG optic neuritis. And compared to adults, children with MOG antibody have a lower risk of relapse. This is another case of an 8-year-old boy with visual disturbance in his right eye. His visual acuity was no right perception in right eye, and as you can see, his right optic disc was swollen. Also, we can spot the optic nerve thickening and strong enhancement along the entire optic nerve. After steroid therapy, his right vision improved to 20/20. Although he got optic atrophy as play, he has not experienced any recurrence after the optic neuritis. In summary, pediatric optic neuritis has some unique clinical characteristics. In addition, each subtype of optic neuritis, based on the disease etiology, shows disease-specific clinical and radiological features. Clinical suspicion of multiple sclerosis, aquaporin 4, or MOG-related pediatric optic neuritis mandates thorough investigation with MRI, CSF analysis, and serologies. I'd like to emphasize that early and accurate diagnosis with a thorough investigation can facilitate timely treatment and predict prognosis. That concludes my presentation. Thank you for your attention.
Thank you, Dr. Moon. That was really very nice presentation. You elucidated the differences between the pediatric optic neuritis and adult optic neuritis. What are the features? What are the differences? And you rightly pointed out that the visual acuity loss is much more, but there is better recovery in the generally speaking. Although we have to differentiate whether it is neuromyelitis optic spectrum disorder or myelin oligodendrocyte glycoprotein antibody disorder. That differentiation has to be made. But I think that's very nicely carry home messages that you have given it to us. Thank you. Any made by any of the panelists or any questions? I think Dr. Moon will love to answer those questions. If not, I think then we'll move on to Professor Kyung Woo Kim, and he's going to tell us the differences. Varicella zoster versus herpes simplex virus. They are similar but different. I think very important talk.
Thank you.
Kim.
Okay. Good evening. I'm so happy to have a presentation in this wonderful meeting. I'm going to talk about the two viruses, varicella zoster virus and herpes simplex virus, which look similar but actually quite different. A human herpes virus family includes various viruses and further divided into three subgroups: alpha, beta, and gamma. Among of these, herpes simplex virus and varicella zoster virus and CMV virus are well known to involve ocular surface. These two viruses are in alpha subgroup, but CMV virus in another group, so CMV virus can make another features in the ocular surface. HSV and zoster virus differ from CMV in terms of the tissue tropism. And HSV and zoster virus like nerve, so these are neurotropic viruses. They lie in trigeminal ganglion and conduct exoplasmic flow to corneal surface. Sometimes they go through the path to the iris, so may induce iritis and iris atrophy. But on the other hand, the CMV virus is immune cell trophic. CMV virus primarily hides in the bone marrow and secondarily lies in the trabecular meshwork and ciliary body. In this reason, CMV endothelialitis increases intraocular pressure very frequently. It may be directly shed into the aqueous humor that make cone-shaped KP at the corneal endothelial layer. HSV and zoster virus have dual phases for their pathogenicity. And HSV and zoster virus usually infected primarily in children. HSV make vesicles on the eyelid or lips by contact, and zoster virus infection is well known as chickenpox, and this is airborne. After days to weeks, viral DNA lie inside the neuronal cells and enter the latent phase. And then usually in adults, when patients are exposed to UV, stress, and immune suppression, new variants are produced again and go to the peripheral target to reactivate the diseases. When we see HSV stromal keratitis or facial zoster in adults, these are almost the reactivation of the dormant virus, not the primary infection. And if patients with facial zoster belong to the V1 dermatome, and if they have vesicles at the tip, side, or root of the nose, we call it Hutchinson's sign. Because nasociliary nerve bifurcates to long and short ciliary nerve to the eye, facial zoster patients with this kind of Hutchinson sign may have much higher risk of ocular inflammation and corneal denervation. The representative feature of HSV keratitis is dendritic ulcer. It has terminal bulb and contain live viruses. When the dendrites become united, they transform into geographic ulcer. But on the other hand, pseudodendrites may be seen in zoster keratitis. These kind of pseudodendrites are hipped up in the epithelium and look like medusa. They do not have terminal bulb like this kind of dendritic ulcer in HSV, usually located in the peripheral lesion. Although each epithelial lesion is quite specific to HSV and zoster virus, the other corneal lesions such as stromal keratitis and deciform corneal endothelial keratitis and keratoivitis are both seen in HSV and zoster keratitis, and those findings are very similar to each other. When we plan the treatment in HSV or zoster keratitis, we first should already know if there are live viruses in that lesion. First, for epithelial keratitis, live viruses are present in the epithelial cells, so the antiviral only is sufficient occasionally. But for the stromal keratitis or endothelial keratitis, the presence of live viruses are not guaranteed, but the immune hypersensitivity mechanism is rather involved. So in HSV or zoster stromal and endothelial keratitis, the administration of steroid is also usually recommended with antivirals. We can use the same antivirals such as acyclovir and valacyclovir and famciclovir in both HSV and zoster virus. But the biggest difference is the effective dose of antivirus between these two viruses. For example, zoster viruses needs more than twice dose of acyclovir than herpes simplex virus. So there's a big gap of dosage between these two viruses. Personally, I like to prescribe valacyclovir thanks to the lower dose than acyclovir. So for zoster keratoivitis, I prescribe valacyclovir 1000 milligram twice a day. This dosage exceeds the effective dose of 50% of effective dose in the tear film and also in aqueous humor. So it really works in the real clinics. In addition, the latency pattern is unique, especially in zoster virus. Although both these two viruses lie in neuronal cells during the latent phase, zoster virus also lie in dormant in satellite cells. The virions in satellite cells can easily spread to adjacent neuron. In this reason, we should cover zoster virus with a systemic antivirus to suppress reactivation. Moreover, the local spread of the dormant area may induce the wide and multiple lesions with more severe inflammation. In my research experience, the early decrease of corneal sensitivity in herpes zoster ophthalmicus patients was significantly related with the diffused corneal punctate epithelial erosion, not by corneal pseudodendrite or other lesions. I think that such wide and diffuse lesions may reflect the higher number of virions in ganglion and the multiple involvement of corneal nerve fibers rather than such of pseudodendrites. Zoster virus reactivation is sometimes very frequent, repeated, and unpredictable. In this 38-year-old male, he had initially pseudodendrites predominantly at nasal area in his left eye. Then pneumolar keratitis occurred. Thereafter, keratoivitis recurred several times with the inferotemporal stroma infiltration. Because his kidney function was bad and an IOP was fluctuated, I really had trouble to manage this patient. And I had also experienced atypical zoster keratitis. This 39-year-old female had keratoivitis, but corneal lesion was involved, both multi-stromal layer by anterior segment OCT and also in endothelium. Although this is not the same as coin-shaped KP as seen in CMV endothelialitis, I was confused with CMV endothelialitis initial visit because her IOP increased very frequently. So after the long intake of antiviral agents, unfortunately, the endothelial scar decreased, but remained in the final with corneal irregular astigmatism. In summary, HSV and zoster virus belong to the same family, but clinical manifestations are quite different. Especially zoster virus-related ocular reactivation may recur very frequently and unpredictable, and sometimes very severe. When once the significant ocular involvement occurs by zoster virus reactivation, the active and steady treatment with sufficient dose of systemic antiviral is recommended. This is my end of my presentation, and thank you for listening. Thank you.
Thank you, sir. I think, again, it was a very nice presentation. Yeah. Welcome, Dr. Kamaljeet, sir.
Yeah, how are you, Dr. Balla?
I'm absolutely fine, sir. We have been having, we were missing you.
This was a very nice talk.
Yeah.
I just wanted to ask one question from the speaker. How long would you like to give steroid in a case of stromal keratitis?
Thank you for your good question. For zoster keratitis, you mean?
Yeah, zoster keratitis.
Yeah, as you might know, zoster keratitis repeat very frequently. So I usually primarily use a topical steroid, prednisolone, and when he or she has very severe episode, then I add the systemic steroid also. But it is not a long time, but I usually depend on the topical steroid for a long time. It may be more than 2 or 3 months, but depends on the recurrence pattern, maybe, I think.
Thank you so much. Thank you.
And you said there is a difference in the dose of valacyclovir, systemic valacyclovir in recurrent herpes simplex keratitis versus herpes zoster keratitis. So what is the difference in the dose, sir?
For the zoster keratitis, I usually prescribe twice more than herpes simplex virus for acyclovir or valacyclovir also. And for the maintenance therapy or to inhibit recurrence for zoster keratitis, I usually prescribe valacyclovir 500 milligram twice a day. Yeah.
Thank you, Dr. Kim. That was a
Dr.
That was a
Kim,
wonderful talk.
it was.
May I ask something?
Go ahead.
Dr. Kim, 2 questions. First, what about that first case? You said the patient was a steroid responder as well as some kidney problem. So acyclovir couldn't have been given in that patient. So how did you manage that case? That is one. Second, in India, most of the patients of herpes zoster, we find only epithelial form, and hardly we ever required to give steroid in such patients. The primary problem is this epithelial healing part. How often you see zoster stromal keratitis in your setup? And yes, these 2 questions I would like to hear from you.
Yes, thank you for your question. For your first question, in that male patient, so I usually maintained a topical steroid for that patient, and that slide, the last visit was 1 year ago, but recently he came back to my clinic, and he also had the recurrence for his pneumococcal keratitis. So when I repeat the topical steroid, and he get better very soon. So I usually now use just flumethylene, the low potency steroid, and it is okay now. And for your second question, I think the pseudodendrite and stromal keratitis is not the parallel disease entity, but it is sequential. So after pseudodendrite, and it get better, and after a few weeks or few months later, the stromal keratitis or keratoconjunctivitis can recur frequently. So at that period, I usually use steroid. But for the pseudodendrite, because it is a kind of initial presentation, I usually use systemic antiviral. But almost dermatologists also prescribed usually.
Thank you very much.
Professor Kyung Kim, it was really thoughtful and nice presentation. It was really good summarized management of the antiviral, the management for the viral keratitis. I think the prevention of the recurrence is really important matter to management of the herpetic or varicose keratitis. For your strategy, I wondered how long and how much you used antiviral medication for prevention of the recurrence.
Yeah, thank you for your good question. I think this is a very fundamental question for treatment of both viruses. Actually, in my own opinion, I do not like to prescribe long-term oral medication because so many patients do not want to take oral pills a long time. So, but for zoster keratitis, it recurs so frequently, and sometimes it is so severe. So for that very repeated patient for zoster keratitis, I usually use valacyclovir 500 milligram once or twice a day for at least 1 or 2 months, and then I must use. I think we must use a topical steroid, although it would be a very low potent, but we always back up with topical steroid also.
Thank you for the answer.
Yeah. What about recurrent keratouveitis and herpes simplex keratouveitis? There's a patient having recurrence about 40 years old, and he's having recurrence almost thrice or 4 times a year. In that case, how long will you like to give the systemic valacyclovir in this patient?
For HSV patient, you mean?
Yeah.
Yeah.
He's basically having herpetic uveitis.
Yeah. I think I'm not sure because the patient in another country or other country will be in the another circumstances. So the recurrence pattern, I think it will be quite different each other according to the country. I think the Korean patient also have recurrence frequently, but I think herpes simplex virus not recur so much than zoster virus. So I usually do not use the maintenance preventive or medication when he or she have a recurrent attack. Then at the point I concentrated to treat at that time. I usually do not use preventive systemic therapy for HSV patients.
To use for 3 months, valacyclovir, like you said, in herpes zoster patient, you use for about 2 to 3 months, 500 milligram once or twice a day. In this case, what would you like to use for 2 to 3 months, sir?
I didn't hear well. Can you tell me one more time, please?
What I said was that in this patient of recurrent herpetic uveitis, will you like to use the valacyclovir once or twice a day for 2 to 3 months?
In my patients?
No, in the patient which I have told you, sir. Like you said, in herpes zoster, you like to use for 2 to 3 months. In HSV uveitis?
For HSV uveitis, I also use antiviral agent, but for the uveitis, I think I am not sure because it is a hypersensitivity or active reactivation. So I usually prefer steroid, but I also use valacyclovir for that HSV uveitis. I do not prescribe more than 1,000 milligram a day. Just I use 500 milligram once a day or twice a day also.
Right, sir. Thank you. Thank you. I think, do we have the next speaker? Dr. Kudlu is there? Dr. Kudlu is going to speak on practical pearls in keratorefractive surgery, and after that, Dr. Amit Porwal. I'll just see. Dr. Kudlu, are you there? I'll just...
I can't say either of them, sir.
Yeah, Praful, any comments on this wonderful talk regarding differences between the varicella zoster virus and herpes simplex keratitis? You are a cornea person, and I know that you get not only patients from RP center, you get a lot of referrals regarding these cases. So any take-home messages, any points you like to make?
I think Dr. Kim covered almost all the aspect nicely. Only one thing that often it's very difficult for us to manage is post-PK recurrence of herpetic keratitis. Recently, we had a patient where the graft was doing fine for almost 7 years. Then he had a PED, and that was actually turned out to be a geographical ulcer. And we had a very tough time to manage such cases. So, Dr. Kim, any such experience you have of managing post-PK penetrating keratoplasty cases with recurrence of herpetic keratitis?
Yeah, recently I have such a patient after DMEC surgery. The HSV recurred, and it was kind of deep stromal keratitis, but he responded very well with steroid, systemic steroid and antiviral. I think we should also think the kind of situation after endothelial keratoplasty.
From my experience, actually, after the keratoplasty, the management of the herpetic or the varicella zoster case is really hard because we already use a lot of the amount of the steroid even immediately after surgery. So the prevention of the recurrence from the beginning is very important. So I strongly recommend to prescribe the preoperative use of the oral antiviral agent, quite some dose, and then it should maintain up to 3 to 6 months after the keratoplasty. Not only for the penetrating keratoplasty, but also the lamellar keratoplasty. Also, we need to pay attention to minimize any possibility to recurrence of the viral disease.
True.
Yeah, I had a very atypical case, a patient whom I had operated about 2 years back, phacoemulsification done, nicely recovered. About 3 months back, he developed dendritic keratitis. He was treated with the topical antiviral, recovered nicely. And just last week, he came with sort of corneal lesion, corneal epithelial lesion, and it was lying on the, it was sort of dendrite, but it was lying on the corneal main port incision over there. So it appeared to be recognized. I again started treatment with the topical antiviral. He's recovered, but I was really scared the type of lesion which he had on the main port incision. So any take on this, any experience of having encountered such kind of cases? Because for me, it was, I had seen for the first time on the corneal lip. And how should, is my mode of treatment okay, or I should give, now since he has developed recurrence after 2 months only, should I start systemic antiviral also in this case? Dr. Praful, your comment?
One thing that I would like to know from my Korean counterparts is, do you have topical acyclovir available in your country? Because in India, we do have topical acyclovir as well as ganciclovir. So our approach to manage epithelial form is primarily topical acyclovir only. We resort to oral only when, if you go through the head's recommendations, like it's endothelitis or it's a keratouveitis, then only we resort to oral acyclovir. As in your case, it was only epithelial recurrence, so you could easily give acyclovir 5 times or maybe ganciclovir. That is sufficient enough to take care of epithelial lesions.
Yeah, topical acyclovir, yes.
I think you have to conclude, sir.
No, Dr. Kudlu,
one thing.
No, Dr. Kudlu just called me that is joining. So meanwhile,
So in the meantime, you can ask our speakers, if you can request the admin also to open the chat box. We can share our email ID so that we can exchange information cases in future. Or else, what's the point of having a collaboration between two societies? The chat section is disabled.
I'm not able to contact the audiovisual person, the IT person.
Hello, excuse me.
That is disabled.
Hello.
Hello.
Sir, it is enabled now.
It is enabled.
Yes. So I think Dr. Bhalla can tell you better, because we both are a member of Delhi Ophthalmology Society, and we also are editors of a journal, Delhi Ophthalmology Society, those times. So I would request you all to please share your experience. We can publish that in our journal. That will be nice and useful to our readers.
Yeah, very true, Praful. I think you have echoed my sentiments only. The wonderful talks which you have delivered, it'll be a privilege for all of us, both of us, to have your talks sent to our Delhi Ophthalmic Society DOS Times, because it's a very informative journal and we have a very wide audience. It's a very popular one also. It's sent to about close to 8,000 members all over the country, all over India. So if you could, we'll just share our email ID. Praful, you can share email ID on the chat box. And
yes.
Just all of the speakers to please send your talk only to our DOS Time journal, because it
not talk related write-ups.
Yeah, the further, yeah.
Nobody's going to send you talks.
No, not the talk. The topic, the title topic, like the
something related to that.
Inherited retinal disorders. Differences between herpes simplex and varicella zoster. All these, I think, talks. The mixed talk was very informative. So all these the topics, if you could send to our journal, that
I think Sir Kudlu sir joined.
Yeah, Dr.
Hi.
Good evening,
Dr. Kudlu, waiting for you. Yeah, please.
Just I'm enlarging my screen. Just a minute. Can you able to say? I think can I start my presentation?
Please.
Yeah.
You love to share your screen.
I'm so sorry. Actually, I'm in some of the periphery. That is the reason I could not able to do that. I'm sharing my screen.
Yeah.
Can you?
Yeah, we can. Dr. Kudlu is a member scientific committee, AIOS, All India Ophthalmic Society, and is a prolific phaco and refractive surgeon from Karnataka, Udupi.
Yeah, I try to share my screen. There is some problem. I think
Just see, IT person, just see, Dr.
Yeah.
Help Dr. Kudlu to share his
Yeah, I can
presentation.
stop sharing again. I can share one more time. Can you able to see?
Yes, sir. We can see your presentation. Yeah, we can see the slides. Please go ahead.
Yeah, you can hear me, no, Balaji?
Yeah, we can hear you loud and clear, sir. We can see your.
Yeah. Thank you so much. First of all, I apologize for delay in login. So Namrata Sharma wanted me to touch in between you all glaucoma persons. Balaji also well-known glaucoma person in India. Amit is also part of this meeting. Once again, I thank Namrata Sharma for this wonderful opportunity. So in between all other specialty, I'm trying to push some of the practical pulse in refractive surgery. I don't have any financial disclosure for this particular talk. So we all been knowing laser refractive surgery has been evolved, is like a full circle. We started with surface ablation, then we go on to do the LASIK. Then later on, we started doing wavefront and customized treatment, then femto-LASIK. Then we have been doing SMILE since last 8 years. Again, we are switching back to the surface ablation. So it's like we are evolving around the circle. So how to achieve the good results? First, in 5 points, I'm going to discuss with you. That is, one is patient's evaluation, preoperative and postoperative counseling, operative equipment and operative measures, and postoperative management. Coming to the patient evaluation, I personally feel that all patient, whoever I am doing refractive surgery, I do cycloplegic refraction, whether myopic or hypermetropic. Of course, you have to do cycloplegic in hypermetropic. Even I do it in myopic also, because always I want to rule out the pseudomyopia. So coming to the patient evaluation, very important. Slit lamp examination is also very, very important. Just we have to always rule out some of the lead pathologies like mebobonitis. We need to look at the tear film status. We need to look at the corneal, whether the patient is already having some corneal abnormality like corneal dystrophy, corneal scars. Always do not forget to see the pupil size. Very, very important. And always look for the lens detail. To know for the lens detail, I think it is very important whether patient is having cataract or not. Also, you have to see. Always you look for any active infection in the eye or any inflammation. If the patient is having any infection, I think you have to treat, review patient after 3 weeks, then think about the treatment. Coming to the always never ever forget to rule out glaucoma. If you think that the disc is abnormal, always all my patients who are undergoing refractive surgery, I just do their visual field testing. I go ahead with the treatment. And also we have to remember post-operatively increasing the intraocular pressure. Also, you have to keep it in mind, especially in case of myopic. So detailed fundoscopy is also very, very important. Suppose patient is already having some lattice with degeneration, normally with holes, we have to treat that. After treating that, then we may have to probably call the patient after 3 weeks for the refractive surgery. This is very, very important. So detailed fundoscopy in all my refractive patient I do, whether it is myopia of 1 diopter or whether it is a myopia of 10 diopter. Detailed fundoscopy is must and should. So of course, lot of tomography machines are available. I do have got pentacam. This is very, very important. See, whatever the topography which can take out the both anterior and posterior map, you need to have with you. Especially this will help in detecting all abnormalities in cornea, keratoconus, even early suspected ectasia, postoperative also. And topography also help you to plan for topo-guided custom ablation. Coming to the patient evaluation, normally we opt for wavefront aberrometry, especially patient when important in we treat for irregular cornea, post-cataract or post-refractive treatment, high astigmatism. Always we plan for custom ablation due to always also very important in case of when you are planning for when you want to go for a custom ablation. Pachymetry is one of the very important tool, especially when you are evaluating for refractive surgery, because now people used to think about two scenarios. One is percentage tissue altered and residual stromal thickness. But once again, now our main aim, why we have to do pachymetry, how much is going to be the residual stromal thickness. This is very, very important. This will give us an overall picture, and also very important, whether to do C3R, whether to do SMILE, whether to do along with the cross-linking. This is very, very important. And general examination of the patient, always try to rule out connective tissue disorder. I'm sorry. Try to rule about thyroid disease. Young females, very, very important. Always ask the female pregnancy history. If the patient is pregnant, do not do refractive surgery. If the patient is lactating, always tell her to come after stoppage of lactation after 6 months. This is very, very important. And ask the patient about the medications, especially patient on any of the steroids or immunomodulators. I'm sorry, I just have a glass of water. The preoperative counseling is very, very important. Always you have to sit with the patient. See, I have done probably one of the highest number press beyond in India. I myself counsel the patient. My chair time for my press beyond patient is 45 minutes. I always sit with the patient. You have to tell about the what and all going to be the complication. Also, you have to discuss with them. You can even show all this literature. ACRS literature shows almost 96% of the patient achieve 20/20. Always very important that to see that always you should promise less and deliver more. Okay, sorry, there is something happened to my screen. Okay, there is some problem happened. Okay, sorry. Can you able to see Balaji?
Yeah.
Yeah. Yeah, it's fine, no? Yeah.
Oh, it's fine. It's fine. Please carry on.
Yeah. Coming to the operating equipment, always still my friends are doing with the microkeratome. Always pay attention for regular maintenance and calibration. Always when you are having femtosecond, try to update your both software and hardware. Even a lot of machines nowadays, even with the femto machine coming with the iris registration, also you need to always, when you are doing with the femto, always look for always lower energy pulse. These are the lot of equipment femto machines available in the market. Okay, so always being a surgeon, during the surgery, I double check all the measurement, make sure that we are enter the proper power, refractive power in the machine. Then coming to the I'm sorry, operative measures, always when you're treating females with a long hair, always head position is very, very important. If they're having a long nose, tilting head bit towards the opposite side, this is very, very important. What should be our goal? Always successful application of the suction cone for femtosecond laser is very, very important. Always during, some of the patient will be very anxious. Even we give them preoperative oral anxiolytics, where I give them, and I keep talking to the patient, especially during the microkeratome pass, also whenever there is, when I'm giving the femtosecond laser application. So that makes the patient calm. So coming to the, I think larger flap is very important when you're doing hypermetropic patient, when you're doing the microkeratome. Always what should be our aim? Save more corneal tissue. That means, as a general rule, use a spheric treatment if the patient has no symptomatic abrasion and is best corrected visual acuity 20/20 or better. I always prefer to do an ocular wavefront in patient with the symptomatic abrasions and with the initial best corrected visual acuity worse than 20/20. Normally, I pick up corneal wavefront in patient who needed a treatment and have a best corrected visual acuity worse than 20/20. Then coming to the center of your ablation, this is very important. For aspheric treatment, the center of the treatment should be the corneal vertex when you're doing LASIK treatment. For customized wavefront treatment, it should be always be on the pupil center. These two things you have to remember. So, of course, as I said that, this all I'm not going to talk. What it should be clean, sterile environment. I'm not going to talk. For I think those are doing those are doing PR case. I think mitomycin is an extremely useful drug. I think depending upon the refractory error, we apply the mitomycin. So I think I'm not going to talk what we do in PRK. I think most of us been doing. Coming to the post-operative measurement, very, very important. So always, these are the complications can happen with LASIK. I do have an incomplete flap, free cap, buttonhole, flap tear. In such cases, stop the procedure, repose it back the flap, apply BCL. You can plan for surface ablation later on. Suppose suction loss during the smile, you can recenter the cone, follow the machine guidelines regarding the continuation of the treatment, immediately dock it. Still, you cannot, in the initial part of smile, still you can convert to the frontal LASIK. Still, in other steps, still you can plan for surface ablation later on. Very important, coming to the post-operative management. Be vigilant, be aggressive in management of complications like corneal infection, diffuse lamellar keratitis, interface fluid syndrome, ectasia. Very important, explain frankly in detail regarding the complication and do not hesitate to take second opinion in such cases. This is very, very important. I'm not going to talk about some of the case scenarios. These are the few case scenarios. My talk is only for 10 minutes. So in the end, very important, careful patient selection and well-planned treatment gives the most happiest patient. Once again, I thank ICO Namrata for this wonderful opportunity. Thank you, Anand.
Yeah, thank you, Dr. Kudlu. I think that was a very nice talk. That really explains why you are such a successful refractive surgeon. The way you deal with your patients, technical details, everything. I think very wonderfully covered topic. Dr. Kamaljeet sir, any comments on talk by Dr. Kudlu?
Sir, good evening, Kamaljeet sir. Good evening.
Yeah, how are you? How are you? So it's very good talk, Dr. Kudlu. I enjoyed your talk, and as you have rightly said that all retinal degeneration should be checked before doing any LASIK. That should be there. When do you do a smile, Dr. Kudlu?
Especially my oral, like if I like per month, normally I give the option for all the treatment. I got PRK, I got LASIK, I got frontal LASIK, and I also got smile. Depending upon the package, if they're having a higher refractory error, more than 5 or 6 diopters, normally my first preference will be smile.
Okay. And then what are your results of transepithelial LASIK?
PRK results are excellent, sir. Very good. Okay. Only thing is your mitomycin management is very important. If you do it properly, like per diopter, how much second you apply the mitomycin, that gives you the best results.
So between the LASIK and transepithelial LASIK, which will you prefer?
See, once again, sir, depending upon the package also, depending upon their topography report also, and also on the refractory error. So suppose the cornea is slightly towards flatter or steep, then I may opt for PRK. Okay. If everything, all parameters are good for LASIK, still LASIK, I do it. But nowadays, patients are more opt for femto LASIK rather than blade LASIK, sir.
Okay, that's great. Thank you so much. Thank you, Dr. Kudlu.
So before we end, I'll just like the IT person to take a group photograph of all the speakers, panelists.
Dr. Balla,
Dr. Balla, Dr. Amit, yeah, Dr. Amit has joined. I think now
I'm there from a long time.
We were missing you, Dr. Amit.
My connection was unstable. So do we have time? Do we take my talk or we shift over?
No. We will have your talk, Dr. Amit. Dr. Amit is the last speaker. Yeah, Dr. Amit, please carry on. You can share the screen.
Yeah, is my slide visible, Dr. Balla?
Yes, it is visible, Amit.
Yeah, so I'm going to talk on combined surgery, that is phaco-trap. No financial disclosures. So why do we do a phaco-trap? Because one surgery helps in both clearing up the central vision loss from cataract and in controlling the peripheral vision loss from glaucoma by lowering the IOP. The possibility of worsening cataract following glaucoma surgery alone is eliminated, and after glaucoma surgery, subsequent cataract surgery may induce inflammation, causing glaucoma surgery to lose its effectiveness or even fail. So phaco trap provides early visual rehabilitation of the patient with cataract and glaucoma and reduces the risk of early severe post-operative pressure elevation. It also provides long-term reduction of IOP and decreases the need of glaucoma medications. So what are the indications of this triple surgery, that is the phaco trap plus IOL? A patient with cataract and a glaucoma patient who is having failure to achieve target pressure by medications. There are issues related to compliance and adherence to medical therapy. There is an adequate IOP control but significant drug-induced side effects. There is a borderline controlled IOP with a disease progression on near maximum medical therapy and is moderate to advanced glaucomatous damage. So these are the indications to do a combined phaco trap. So what are the techniques for phaco trap? You have the single site technique and the twin site technique. Single site technique, basically the phaco and trap is done through the same site. It has less surgical time. Twin site is phaco is done through a separate clear corneal temporal incision as the first step, followed by trap at the superior limbus as the second step. It involves more surgical time. But when we look at single site versus the twin site group had 1 to 2 millimeter more IOP reduction and required less post-operative medications, but although the difference was not statistically significant. So coming to a video on basically the two techniques, the single site and the twin site, I'm just going to show this video. It's taking some time to load. My internet connection is really unstable today. Still, the video is not running. Dr. Valla, can you see the video running?
No, no, Amit.
No, it's still loading. Yeah. Yes, this is a case of trap plus phaco. It's a triple procedure. So in this, what is very important is taking the corneal stay suture or the superior stay suture and then marking the conjunctival flap. So usually when I do a phaco trap, I mark it at 3.5 to 4 millimeters. So you mark your conjunctival flap and then do a subconjunctival dissection. Cut at the limbus in one go and do posterior subconjunctival dissection as much as possible so that you have a diffuse posterior flap. So you have to do this on either side of the cut end of the conjunctival flap and also behind as much as possible. Try to identify the bleeders and cauterize only the bleeders. Don't generalized cauterization should not be done because that will lead to shrinkage of the scleral flap once you do the scleral flap. If you are using any antimetabolite with the pipe or mitomycin, count the number of sponges which you are going to use it. You should have your titrate your own holding period of this mitomycin and the concentration of the mitomycin. After the holding period, when you take out these sponges, always count and take out. You don't want any of the sponges to be missed. Usually what I do is because there's conjunctival chemosis, when I wash out the antimetabolite, so I iron it out and again I mark my scleral flap to 3.5 millimeter. I always do a triangular flap, but you can do a triangular flap or a rectangular flap whichever you're comfortable with. So I mark my triangular flap 3.5 by 3.3 millimeter and then lift up the apex of this triangle. So you hold the apex of the triangle and lift it up in the air and with the help of 15 number blade, just touch the cutting edge of the 15 number blade at the junction and you will see that you will get a uniform flap. But the key to this is that you should always stretch the apex of the flap superiorly into the air. Then this is a twin side phaco surgery, so I shifted temporarily and then you do a start with a normal phaco surgery. So this was a case of complicated cataract with secondary glaucoma with a small pupil. So as a cataract surgeon and a glaucoma surgeon, you need to plan out how you're going to manage this small pupil. So I did a cyanocolysis. I achieved a bit of mydriasis, but this was not sufficient for my case. So then after removing the clear corneal incision, I thought of using a Malugin ring. Now this Malugin ring, it sits on the iris plane and it makes your phacoemulsion procedure more safer. So you can see that the distal scroll is engaged into the pupillary border and the two scrolls are engaged. So and then the Malugin ring is scroll is engaged. These devices lie at the pupil, so your phaco is not disturbed. The routine phaco, whatever you're used to, you can do it. But what I advocate should do is to do a small, slow motion phaco emulsification. So managing the small pupil as a glaucoma surgeon is very, very important because we come across a lot of patients with this small pupil. So now you can see the rexis being performed. An adequate 5.5 millimeter rexis is performed. Once the rexis is completed, then basically you have to do a hydrodissection. Again, you have to be very careful that you should not overdo the hydrodissection. You should do a gentle hydrodissection and then proceed with your phaco. My preferred technique of phaco is basically a stop and chop technique in which I make a central trench, divide the two hemispheres into two, separate the two hemispheres once the central trench is made. Then each hemisphere is further subdivided into 2 to 3 small pieces and then these are emulsified and aspirated into the phaco probe. Once this is done, the cortex wash is done with the help of a bimanual. I always prefer a bimanual because it gives an easy access 360 degree. And after the cortex wash is done, whatever PC polishing is needed, that is to be done. And this IOL is ejected into the capsular bag. So this is the procedure of phacoemulsification with IOL implantation in a combined surgery. Once this is done, the malignant ring is taken out with the help of a bimanual technique. You can just disengage it from the pupillary border and then withdraw it with the help of an injector or with the help of a forceps, whatever you're comfortable with. So once your phaco is done, then you again move superiorly. Now lift up the triangular flap and see whether adequately it is the blue-white junction is exposed or not. Now you can prepare the internal ostium with the help of a 11 number blade, an MBR or a Kelly sponge, whatever you're comfortable with. If I'm using a 11 number blade or a MBR, I make a 2 by 1 millimeter internal ostium, and a broad-based peripheral iridotomy is done with the help of a LIMS forceps and a 1 hour Caesar. Earlier, what I should do is intermittent apical suture is used to be placed with the help of a 10-0 ethicon. But now what I do is I place a single releasable suture at the apex, and that's all. So it all depends on how you titrate your surgery. So what usually for beginners I recommend is 1 apical suture intermittently and 2 releasable suture on either side. Now how do you prevent? What I do is I pass the suture into the clear cornea in front of the limbus, and then perpendicular to the limbus from the clear cornea into the scleral flap, and then from the scleral flap into the intact sclera. So whatever loop is created over the scleral flap, now this loop, the 4 throws are passed over this loop, and you can see once the 4 throws are passed, you can tighten it. The advantage of releasable suture, it provides a tight AC, and post-operatively you can titrate your blood by releasing the releasable suture and keeping the AC adequately formed. And this is the advantage. The conjunctival suturing is very, very important. You should always take the episcleral suture at the limbus, so that and you put interlocking sutures with 80 Vicryl. You don't want to make sure that you take the episcleral anchoring suture, because if you don't take that, then with the late movement, the blood conjunctiva will get retracted posteriorly, the blood will get retracted posteriorly. So the key is take a proper suturing. The next, there's one more video I'm showing on a single, basically single site surgery. Dr. Bala, am I audible?
Yeah, you are audible. Can you?
Yeah. So this is a small video clip of a single site surgery in which a trap and phaco is done to the same site. Now, how does this differ? Basically, we being most of the surgeons are temporal phaco surgeons, so it becomes a bit difficult to do the surgery to the single site. But there are surgeons who are superior phaco surgeons, and for them it is a very, very good surgery, because it is more relaxing for them, because they are used to the technique which they are doing it. So, as I told earlier, also a superior rectus suture has to be taken, taking into consideration that you get a nice anchoring. 3.5 millimeter is marked on the conjunctival flap. But this is very, very important. You should not do a blind procedure, because you should always measure the flap and do it, because in the future, if the trap fails, you know what was the site, where was the site, and how much congenital dissection you have done, so that you can do a repeat procedure also if needed. So you see, in one go, I've cut at the limbus, and with the closed Caesar, I'm going in the subcongenital space and trying to open it, so that the tissue gets separated, and there is as much as posterior dissection as possible, so that whatever aqueous egress is out, it is going posteriorly, and we have a diffuse posterior bleb. After that, as I told earlier also, the cauterization part is very, very important. You identify the bleeder and cauterize only the bleeders. If you do excessive cautery, once you make the triangular flap, you can see that the flap gets shrinked, and there's a unevenness in the size of the flap. So again, mark the spiral flap, as I told you, 3.5 by 3 millimeter, and again triangular or rectangular, whatever you are comfortable. This is very, very important. You should know the depth of the incision when you are taking. It should be more than half the thickness of the depth. And if at all there is any ooze when you are doing this congenital flap or a scleral flap, you can always cauterize it gently, or you can just use a wet sponge to pressurize it, and the bleeding gets stopped. You can see I am lifting up the apex of this triangular flap, and I'm just cutting the triangular cutting edge of this 15 number blade at the junction. You always make sure that you tell your assistant whenever your view is off, just touch this wet sponge at this junction, so that you get a nice view, and you just touch the cutting edge of this 15 number blade. So wet sponge plays a very, very important role. In this case, mitomycin was used, but it was not used intraoperatively. It was not used after making of the congenital flap. Before I started surgery, I injected 0.1 ml of mitomycin, that is 0.02 milligram subconjunctivally, as much posteriorly as possible, superiorly. And after holding period of 2 minutes, I started with my trap surgery. So you can see I'm making this scleral flap. sometimes the sclera is not same in every tissue in every eye. So every eye you might not get a good flap, but sometimes you might get an uneven flap, but you have to be prepared with it. But make sure that you don't press the apex much, because there should not be any cheese wiring or a button rolling of this flap. So once this spherical flap is done, then you do the two side ports. Because I use a bimanual, I want two side ports. But if you're using a coaxial, you can just use one side port in the non-dominant hand, through which you're going to pass the second instrument and stabilize the cataract when you're doing the phaco resolution. So here I'm doing two side ports with the help of a 21 gauge MVR. These are the two side port incision bit I made. Now with a 2.2 millimeter keratome, I'm entering into the anterior chamber. So I'm doing a 2.2 millimeter entry, because my phaco sleeve which I'm using supports the 2.2 millimeter incision. And now sodium hyaluronate is used throughout the surgery. So the rexis is done and the phaco emulsion is being performed on the superior side. So this is called as the single side phaco surgery, wherein the trab incision and the phaco wound is in the same site, and that is the superior side. So as I told you, prefer technique of stop and chop. Make a central nice deep trench, separate the two phases, and inject the IOL. Now with the help of a Kelly sponge, I'm making the internal ostium. So again, the internal ostium, you can shape it in the L shape or a mushroom shape. So whatever you're comfortable with, you will always try to titrate your own skills and try to make sure whether you want to do an L-shaped opening of the internal ostium or a mushroom-shaped opening of the internal ostium. So this is a 1 millimeter punch which I'm using it, and I'm trying to cut the trabecular meshwork. So you can see that throughout the AC is formed, the sodium hyaluronate is injected. This helps. You should not over inject the sodium hyaluronate, because if you over inject, there might be an iris prolapse. So to avoid iris prolapse, you just adequately inject sodium hyaluronate and maintain the AC. A broad gauge iridotomy is done now with the help of the suture. And as I told you, nowadays what I use is only a single releasable suture. So you have to titrate your surgery. Whatever is comfortable in your hand, you have to go ahead with that. So the technique of releasable suture, I have already explained it. So pass into the clear cornea parallel to the limbus, in front of the limbus in the clear cornea, then perpendicular to the limbus. You can see now from the clear cornea into the sclera, into the scleral flap, and now from the scleral flap into the intact sclera, I'm going to pass it. So this is very,
Amit,
very
can
important.
you conclude? Amit,
yeah.
Can you just,
yeah.
Yeah.
So thank you. And that is what I wanted to say in my surgery. Thank you.
Very nice presentation by Amit. You very nicely elaborated the single site versus two site phaco trap. And I think you also pointed out that there's not much difference.
Amit, stop sharing your screen.
I'm doing that. As I told you, my system is a bit slow.
Now we could. I want to see you, brother. Smart Amit Porwal.
So
yes, where is Amit? Yeah. Great. And very good presentation. Very good presentation. You rightly pointed that in a single site. What is your preference? You do single site or double site?
I'm a temporal phaco surgeon, so I prefer a twin site.
Twin site. Yes, even I do twin site because it really helps you in a way that it gives a bit more IOP reduction compared to the single site, and I think it's better. The primary wound of the phaco is not touched, so the double site is also my choice. Sir, Dr. Kamalji, sir, any comments on this?
Yes, it's a wonderful video. Both the videos are very nice.
Excellent.
I also prefer different sites for phaco and trap. Today in the evening, I did one. So I made a triangular flap and did the phaco emulsification from the other side. Okay. So that's a very good technique, and the results are good. Even with SICs also, I have a separate trap opening. Yeah.
Right.
For the SICS tribe, I prefer a single site because the amount of dissection is too high. But if you're doing a twin site, it is really tremendous. I mean, you need a lot of surgical skills.
Yeah. Good. Yes. Whatever is good in your hands, you should do that.
Yeah. Right.
Yeah. So you are moving in the slide. Your internet is not good.
My internet is not stable today.
Yeah, I think it's not stable. But I think so. We come to the end.
You are very stable, so it's good.
Kamalji sir, it was out of 7 scientific committee members, we 3 are in this session. Me, Amit and Vallabh, we 3 are scientific members for All India Ophthalmological Society. We 3 are in the same session today.
And we are privileged to have Dr. Kamalji sir, along with stalwarts of Ophthalmological Society. Yeah.
He is our guru. Kamalji sir is our
guru. Yeah.
I would like to thank the Korean Ophthalmological Society also who are part of this symposium.
Exactly.
For your special participation. I was trying to hear the lectures in between here and there, but thank you once again. Thank you all. Thank you, Kamoji sir.
Thank you. Thank you so much. It's a great session.
Thank you everybody for this wonderful opportunity, and thank you Namrata also to involve.
We thank
oculoplasty people also. We are also watching you all.
Oh, exactly. Really nice to have you, Dr.
Kasturi, you are doing FECO also.
Namaste, namaste. We really enjoyed your talk.
Dr. Bala, you are going to have a
we
group
really enjoyed.
Yeah, I think I was just requesting the IT person to have a group photograph. Can you have that group photograph
And
of
I
all
think
the
the
speakers
plastic
and
people,
panelists?
okay, let me be off now.
No, you come here, Dr. Kasturi. No.
Kasturi, you are also doing FECO nowadays. You are presenting FECO talks on all the conference.
Madam is a fan of ophthalmology. Madam is a fan of ophthalmology.
Yeah, fan of ophthalmology.
See, the difference is we are not able to do oculoplasty, but Dr. Kasturi does very nice FECO.
Yeah, refractive also. She does LASIK, Bala.
My God.
I do ICL, LASIK, everything.
Everything.
Oh,
She's
great.
a fan of the tremendous.
She's a fan of ophthalmologist, exactly.
Thank you.
So can we have the group photograph? I think the person is there or someone can take. Dr. Kudlu,
You can take a screenshot. Let me take I'm taking a screenshot.
Yeah.
Done. It has come out very good.
Okay, thank you.
Yeah.
Thank you.
You also take.
I'll share you in the group. Don't worry, Dr.
Okay.
Thank you.
Yeah, thank you so much. Thank you so much.
Professor is there. So let me take one more. Cheese, smile, smile, smile.
Dr. Usha is also
Welcome everyone.
Thank you.
Yeah, now everybody is on. So now the photograph will be better. Dr. Ganga is there, who's not logged in, who's not showing the photograph.
I can see Ganga. Pallavi is there. Yeah, Pallavi, come please. Yeah.
So everybody is there,
Yeah.
Thank you so much. My phone is almost going to discharge, so please take the photograph fast.
Done. I have taken multiple screenshots.
Bageshwar, you are taking? I think
Yes,
Bageshwar is doing now.
Yeah. Okay. Thank you. Thank you, guys.
Thank you, everyone. Thank you. Good night. And
Thank you, Dr. Bala. Thank you.
Lovely having
for a
all
nice
of you.
session.
Yeah. Thank you, sir. Good evening.
Thank
Good
you,
evening,
sir.
Dr. Grover, sir. We
you.
had a very
Grover, sir.
wonderful
Good evening.
session with Korean
Good
Ophthalmological
evening.
Society. Dr. Wu Kim, Dr. Kyun Jin, everyone. I think the wonderful talks.
Yeah.
Okay. Thank you. Bye. Bye.
Good evening, sir. And good evening, Gunjan, Dr. Kasturi. I've been here.
So nice
I've
to
learned.
see you. Good
I've
evening,
learned a
everyone.
lot.
Good evening, Usha. Good evening, Neelam.
I'm learning a lot of glaucoma now.
Even me, I have attended the full
The past,
session.
yeah.
Welcome, Pallavi.
Evening, sir.
Hi, Pallavi.
Hi, ma'am.
I think we should start our session. We are already running late by 30 minutes. So without much ado, I'd like to introduce our first speaker. Our first speaker, our keynote address would be by Dr. Robert Goldberg, who is ophthalmic plastic and reconstructive surgeon at UCLA, has more than 200 publications, and has been in the editorial board member for several prominent ophthalmic and plastic surgery journals. He has been recognized as Super Doctors by Southern California Group in 2022 and Top Doctors of in Los Angeles Magazine in 2021. He has multiple awards to his credit. And sharing the keynote lecture along with him is Dr. Pallavi Singh, who is orbit and oculoplastic surgeon currently practicing in Ahmedabad, Gujarat. She has done her MD from RP Center AIMS, followed by her senior residency in the subspecialty. She was then selected as a global fellow for 16-month surgical fellowship in orbital and oculofacial plastic surgery under the mentorship of Dr. Goldberg at UCLA. She has more than 30 publications and has presented in various national and international forums and has received several awards. So, Dr. Pallavi, you might share the video or the...
We have a pre-recorded video.
It's 8 o'clock.
Good evening, everyone. It gives me great pleasure to introduce the keynote speaker for this session, my mentor and really, really close to my heart, Dr. Robert Goldberg. I don't think he needs any introduction, so I'm going to dive straight in. We're going to talk about the functional applications of fillers and neurotoxins. I'm Pallavi Singh. I'm an oculoplastic surgeon practicing out of Ahmedabad. So I'm going to talk about functional uses of neurotoxin first, but before that, I'm just going to talk about a few basic principles that we need to keep in mind, whether we are using neurotoxin for cosmetic or functional purposes. The first thing we need to understand is that neurotoxin, as the name suggests, affects the neuromuscular junction. So it acts on the muscle. So we need to know that it addresses animation. So we have, whenever we think about eliminating dynamic lines or dynamic wrinkles, that is when we think about this toxin, and not static wrinkles and folds. And so it's important whenever we talk about the use of neurotoxin that you want to customize the injection pattern. Now we do have the same set of muscles, but the strength of the muscles and the width of the muscles differs from person to person. You know, men will tend to have stronger muscles, wider muscles. So it's important to customize our injection pattern in that sense. You can see on the left that the orbicularis is more widespread, and on the right, it's just around the lateral canthal angle. So depending on how wide the muscle is, we want to customize our injection pattern to be able to get the best possible result. We need to know that whenever we use neurotoxin, it's very important to preoperatively get an idea of what the muscles look like dynamically. And it's important to, you know, see the animation of the face, like I said earlier. And I think it's important to steer clear of the whole, you know, product insert mindset that we have, that you want to inject spots. I think that's just, you know, most of the training programs that, what do you think about that, Dr. Goldberg?
Pallavi, I'm so glad that you're teaching that, and that you understand those concepts, because everyone has different muscular anatomy. And so injecting, you know, the eyebrow or an X or a spot on the face, it doesn't make sense. You have to study each patient, understand where their individual muscles are, which of course requires understanding what each muscle does. And then when you inject specifically into the muscle.
And of course, you want to check the results in 2 weeks, tweak if needed, you know, add a couple of units here or there, depending on how everything's acting up. I'm going to give a quick overview of what the functional uses of neurotoxins. Blepharospasm, you know, this was what originally botulinum toxin was sort of devised for. And I think this is essentially where most of the principles that we talk about become very important, depending on whether the eyelids are involved, whether half the face is involved. I think it's always helpful to either see an episode in person or to have the patient give you a video to be able to understand what exactly is, you know, the involvement of the muscles, and, you know, inject accordingly. And I think there's, Dr. Goldberg, what do you think? I don't think there's any amount of units that we can, you know, you can customize the pattern, but do you have any tips that you would want to give for blepharospasm?
I think, like everything in medicine, Pallavi, you start with the least amount of medicine and build up as you need to. So often I'll start with 20 or 30 units, you know, total around the eyes. And again, we inject the, you know, the muscles, not the spots. And so it always annoys me if I go to someone's office and they just have a picture of a face. You know, I've watched your practice. You have a picture of the muscles and you just indicate how much you've put into each muscle. So you're perhaps 20 units in the glabellar muscles, 5 to 10 units on each side. That's a good start for blepharospasm. Then, as you say, you can see the patient back in 2 weeks. If it's an inadequate effect, you can increase it the next session. But I find many patients are controlled for many years with 20 to 30 units. On the other hand, some patients need as much as 100 units.
Talking about strabismus, again, one of the original uses of botulinum toxin, especially important in infants and pediatric patients, and very useful in patients who've had multiple surgeries where we don't have any muscles left to operate on. I think the most important thing that we need to sort of keep in mind when it comes to using Botox or botulinum toxin for strabismus is that we don't want this toxin to diffuse into the surrounding muscle. So you want to make sure that you have a high concentration of the drug. And instead of using 2.5 cc's to dilute the drug, like we use for cosmetic Botox, I think I would use about a cc. So you have a really high concentration. And you can use either an open or a closed technique. And just inject directly into the muscle. Again, we don't really have good dose response curves for extraocular muscles. So this is just something you have to sort of learn as you go anywhere between 3 to 5 units per muscle is a good starting point, but depending on the age and depending on just how strong the muscle is, the kind of effect you want to customize all of those things. And, you just want to make sure that you tell the patient that it probably will take a couple of times of doing this to be able to get the right amount for that patient. Similarly, one of the other uses that for botulinum toxin that has been described is eyelid retraction. You can inject it directly into the levator muscle, either transcutaneously or transconjunctivally. One of the problems for thyroid eye disease retraction is that it can tend to diffuse to the superior rectus muscle and thus worsen the double vision. And we know that diplopia is just one of the most debilitating sort of features of thyroid eye disease. So I would be wary of that. We tend to use hyaluronic acid gel for these cases in our group. But in cases where you don't have an option, I think it's a great idea. It's a great backup, provided that you counsel the patient and you make sure that you have that discussion with them that the double vision might get worsened over a period of time. One of the newer uses in the past 2 decades, it's, that botulinum has been used for is epiphora, especially used for patients who have increased amount of tearing, who have aberrant reinnervation, crocodile tears, or, just functional causes where you don't really have a surgical cause for tearing. So I think it's a fantastic drug to use in these cases. Again, we want to use a high concentration because, as we know, the levator runs right through the lacrimal gland. So I think if we inject transconjunctivally, I think we have the advantage of injecting under direct vision. But there's still I would say about a 25% rate of ptosis. I don't know, Dr. Goldberg, what would you say that your rate of ptosis is?
Yeah, that's been my experience. And by the way, Pallavi, the other option is to inject the orbital lobe of the gland through the skin. And I personally tend to do that. But the needle is going to the same place either way. So I'm not sure it really makes any difference, right? You're getting the needle tip in the same spot, whichever direction.
Now, this is one of my favorite uses of botulinum toxin, using it for senile or spastic entropion. This is something we usually see where the preseptal fibers override the pretarsal fibers. As you can see, she's squeezing hard and you can see that there's entropion. So typically for older patients, for patients who are waiting for surgery, or patients who are debilitated and, are on blood thinners, I think just using about 10 units in the lower lid, in the lower orbicularis can really provide a good temporizing measure until surgery. And in some patients, I think maybe this might be the end of the problem as well. Sometimes they just, they get one injection and they keep coming back for injections because it's much easier for them to just have like a 5-minute procedure every 4 months. The last use that I'm going to talk about is a chemical tarsorrhaphy, where we inject botulinum toxin in the levator to make the lid fall. Again, very useful in old patients who are on blood thinners, or post-op patients where you expect the condition to resolve. You can either do a transcutaneous or a transconjunctival sort of injection. Again, we don't have good dose response curves, so it might be anywhere between 2.5 to 10 units. You might need to alter that. And there's a high risk of, there is a measurable risk of diplopia, but the eye is closed, so I don't think it really poses a big functional problem. It does come with great advantages. There are no scarring of the lid margin, so that is great, especially for cases where you need multiple tarsorrhaphies. The corneal assessment is very easy. You can just lift the eyelid, you can put in the drops, you can assess the cornea, so that whole ordeal when it comes to assessing the cornea in these cases, I think that becomes easier. But for me, the biggest disadvantage is the lag time, because more often than not, whenever we're doing a tarsorrhaphy, we need to do it stat because the cornea is decompensating. And most of the times you don't really have 2 weeks to wait. So I think that would be the biggest disadvantage for me, but it's still a great option in cases where it can be used.
And the other downside is that, you're stuck with it for 3 months. So, it has, if the cornea gets better, the patient still can't see.
It's a commitment, so you have to commit to it. So I'm going to hand over to Dr. Goldberg to talk about something we love listening to, the uses of hyaluronic acid gel in the eyelid. Dr. Goldberg, please.
Thanks, Pallavi. All of these uses are off-label, but we have a 20-year experience in these treatments, and I think they're acceptably safe. Let's look at the next slide. So let's start with tight scars and dermal tissue expansion. So here's a patient with congenital ichthyosis. And if you've taken care of these patients, you understand that there's really not any great medical treatment for this. So what we do in these cases is intradermal expansion to try to actually maybe a little tissue effect or stretch the skin. And what I've found is that in many patients, just a half a cc in each eyelid is enough to really expand the skin. Of course, it can be repeated at regular intervals, maybe every 3 months or so. And for example, in this patient, Paul, if you show the next slide, you'll see that I was able to create an eye that had really bad lagophthalmus to get enough stretch in the skin to have him close his eye. And we saved the cornea on the other side, and much better than surgery. Also, I'm sure, Pallavi, in your practice in India, you see these patients who've had multiple surgeries with a dense scar in the eyelid. Again, I don't think this is a surgical problem. It's just all biology. And so the next slide, you can see just with multiple injections into the scarred plane, we're able to stretch the tissue and give her some cosmetic and functional improvement in a case that I really believe there's no role for surgery. Now, I've used this for congenital malpositions. Keep it going. So patients with congenital retraction like this, look at this is a little preemie. You can see she's in the neonatal ICU. I don't think anyone's thrilled about taking a baby like this to surgery, but her cornea was exposed. So in the ICU, we use hyaluronic acid gel to expand the tight tissue. Next slide. And we're able to protect the cornea. And sometimes, either because the child grows or maybe, Pallavi, you get some permanent tissue expansion, sometimes even for the rest of their life, you can avoid surgery. At least you can delay surgery until they're older. Same thing here with the coloboma or some type of congenital ectropion. You can see the improvement that we've gotten in eyelid closure with a 10-minute procedure in the unit. Now, we talked about lower eyelid retraction a little bit a moment ago. Next slide. But I've thought about this, and I know, Pallavi, you have talked about this a lot also. We used to think of retraction as just a shortening of the middle lamella. Next slide. And I think that's true. There is some length, but I don't think length is the main problem in these multi-operated cases. I think it's volume collapse. And what we can do so we can surgically lengthen the eyelid just with an end glove lysis. And then what I think is left is not a length problem, but a volume problem. We can put in free fat graft or a dermis strip graft. Next slide. But the other option is to address that volume defect with hyaluronic acid gel. And we can do that without any surgery at all. Next slide. So here's a difficult case, a patient with a very nice lady with unfortunate necrotizing infection. And you can see all the volume collapse. And by the way, she's skittish. She's had too much surgery already. And I don't think surgery is a great answer because there's this volume collapse. So look at what we've been able to accomplish just with a filler alone to try to replace the volume, I guess put air in the tire and lift the eyelid. Cosmetic and functional improvement, completely non-surgical. This is a patient 1 or 2 weeks after surgery, a nice plastic surgeon. I think this is your case, Pallavi. And he comes in, the surgeon's unhappy, the patient's unhappy. And I think the last thing you want to do is drag them back to surgery. But here, just with the gel, we've been able to protect the conjunctiva, reverse the early situation, reverse some of the psychological fire that's burning. And then look at him 4 weeks later, the eyes quieted down, the chemosis is improved, and he ended up not needing any surgery because we were able to stretch things out. The orbicularis came back. And if you can see the before, and if you click again, Pallavi, it'll run the after. If you look at the bottom right slide, you can see the little tiny bubbles of hyaluronic acid gel. You see them here, all lined up along the retractor plane. So one of the things in my mind that I imagine is maybe the gel also starts to reform some of that bursa between the moving layers of the eyelid. And that may be one of the reasons that we're seeing an improvement in this collapsed eyelid. Next slide. Last, let's talk about upper eyelid retraction. Pallavi already talked a little bit about upper eyelid retraction. And yes, you can use botulinum toxin, but Pallavi, I almost never do it because I'm so worried about two things. First of all, getting double vision. which is catastrophic in these Graves patients. They're already on the verge of double vision. And also, it's just so uncontrolled, right? It's going to be all or none. You can't really titrate the amount. And if you give too much, your next chance to titrate it is 3 months. When a patient has ptosis that they don't like, 3 months seems like 3 years, right? Next slide. So here's a patient, young attorney, comes in, early thyroid eye disease. She's miserable. She can't work. She's very self-conscious. Too early for surgery, right? Because she just started with her disease. But here she is in the office after hyaluronic gel injections into the levator plane. Already better. Next slide. Now, the gel will go away over a year. Maybe some of the improvement in the levator function is long-lasting. But even if not, in a year, you have a chance to re-inject or see if maybe the disease is unwinding. But in the acute phase, I think this is a great way to get the patients better. I mean, Pallavi, you did a lot of these injections yourself. What's your impression of the hyaluronic acid gel for eyelid retraction?
I think it's fantastic. And I think it lasts longer than we give it credit for. I mean, I've seen follow-ups come from your clinics that were good for 2 to 3 years. And sometimes that's all they need. They don't really need big orbital decompressions. It's just the retraction that's bothering them. And about 1 cc into the lid, it just does the job for them.
Right. Yeah. Now, sometimes it lasts less time, but you can always add it. Those cases that last 3 years, Pallavi, I wonder if that was just the natural history of the disease. But who cares, right? I mean, you've gotten them through the acute phase. Right. Next slide. So, Pallavi, another really useful trick that it gets me out of trouble is stenting for early overcorrection. So the next slide. I'm sure you've had this happen in your practice. By the way, didn't I teach you that you can never, you remember this case, this was your patient. Do you remember I told you that you can never overcorrect neurofibromatosis?
Yes.
But remember, we overcorrected this young girl. I was just amazed. And she was pretty uncomfortable with overcorrection of the ptosis. Now, you could try to take her back to the OR, but she's a young, skittish girl. And I'd rather not reoperate. It was a bloody surgery. So remember, in the office, we just put a little bit of gel into the levator plane. And this is the technique, just going along the plane of the levator. I usually go through the skin these days. You have to be careful not to go into the globe because it's a pretty narrow spot, but you can find your way into that plane. Next slide. And the nice thing is that we relaxed her right away. And now maybe this will stretch it out because you're doing this in the early phase after surgery, right? So maybe it's like releasing the suture in the levator where it's
exactly.
This is a patient. Do you remember her from Hawaii?
From Hawaii. Multiple surgeries.
Multi-operated years later. She's really just distressed by this, the retraction and the hollowness. And she has a scar in the posterior lamella. So it's a very difficult case for surgery. Next slide. But we were able to, just in the office, by doing a little bit of injection into the levator plane and a little bit in the superior sulcus, make such a nice improvement. Do you remember how happy she was? She was like tearful.
She was really happy.
She'd been living with this. And so these are cases that I think are very difficult for surgery, psychologically and technically. Great for the gel. Next slide. And then the last thing I'll mention is that it's useful as like a temporary gold weight. So next slide, you have a patient that comes in with a temporary palsy. This is a good example. I think she had parotid surgery, but they thought that the nerve was going to come back, but she's really uncomfortable from the retraction. You'd rather not have to go to surgery for gold weight, especially if it's going to be temporary, but by putting a cc of hyaluronic acid gel just in the pretarsal plane, you can see that we've allowed just in the office for the eye to close. That'll last for 6 months or a year. And then if the palsy doesn't come back, you have the option of treating it again with the hyaluronic acid or going to a gold weight or some other treatment. Same thing here. Next slide.
So I think it's just basically some of the things that we talked about, like Dr. Goldberg said, you want to treat the muscle, you don't want to treat the skin. So inject the muscles, don't inject the spots, customize the pattern. And especially more important in functional cases, we want to make sure that you're injecting the drug only in the muscle, only in the areas that we want to inject it in. So I think it's really helpful to have a high concentration to prevent the diffusion. What do you have to say about fillers, Dr. J?
Okay, so good. So I think that the most important aspect of the fillers is, I think, the psychological effect and the immediate gratification. Even though it's temporary, it's so useful for eyelid retraction, for tight scars, for dermal scarring, and for temporary gold weight. And it probably has just changed my practice. These patients are often so grateful to avoid surgery. It allows you to get to know the patient, to make a relationship without having to do surgery. Sometimes you can avoid surgery altogether. Sometimes it's a temporary measure until you go to surgery. But it really is a great practice builder. And what you'll find in India is that once people know that you know how to do this, they seek you out, because patients really don't want to have surgery if they can help it. We love doing surgery, but think of yourself as a patient, right? But the patients are so grateful sometimes for a simple option that they can help them to avoid surgery, and you make a lifetime friend and admirer of those patients, and the referring doctors often too.
Thank you so much, Dr. Goldberg, for taking the time for speaking to us about just something which is, I feel, still not well understood. These are newer applications of all of these things that in India we're just beginning to sort of understand in the past, couple of years. So I think it's fantastic.
Okay, but Pallavi, I'm starting to get old, so I'm giving the ball to you now. It's in your court, and I want you to take this field to the next level. Okay, will you do that? Okay. Good night, everybody.
Good night.
So it was a very excellent video, and definitely non-surgical methods are much more appreciated and much more accepted by the patients as compared to the surgical procedures, if we just say for surgery in the first go. So any questions from the house?
Thank you, Pallavi. I think trust Bob to come up with several innovations. He's done more innovations than anybody else, I believe.
I agree. Completely agree, sir.
Always educative to listen to him. The only point that I would stress from our experience is about the use of Botox for epiphora. I think I'm nearly forgetting to do conjunctivodacrosis or rhinostomy since I started doing those canalicular obstructions, which we get so often because of chronic meibomian gland disease in our population, in the older population. And those kind of upper and lower canalicular obstructions are virtually impossible to treat with anything other than a conjunctivodacrosis or rhinostomy or a Jones tube. And those have started doing very well. Most of them do very well with Botox. And I think a ptosis rate of 10% in them is fairly acceptable to them. You warn them about that. I've never seen diplopia though, but ptosis is quite common. And with a few hundred of those, I think, and usually with 2 or 3 injections, they don't then need to come back. They often get permanently better. So my conjunctivodacrosis rhinostomy rates have really dropped after I started doing it. So a very useful modality in our kind of patients.
Sir, I just have a question for you. What is the dose that you typically use? And do you use a transconjunctival or a what is it that you prefer?
We use transconjunctival 2.5 units only. We don't increase anything more than 2.5 units. And it works for at least 90% of the people. Some of them, the effect may last only for 2-3 months, but most of them, it would last about 6 months. They come back after 6, 7, 8 months, and they are happy to get another injection.
Beautiful presentation, Pallavi. I just want to add one more functional indications that we have been doing. It is especially for those inophthalmic socket, and especially those children who had undergone enucleation with a ball implant many years back, or even in seeing eye. I've started using filler for the inophthalmic socket, but that too only with cannula. So what I do, I make an entry with the 18 gauge, then I pass the cannula. And believe me, like it really works wonderful. Maximum 1 cc, but never with a needle, but it should be with a cannula. And it gives an amazing correction, whether it is inophthalmic seeing eye or a non-seeing eye. So that also we can explore more into it, but it is a bit risky. So one should be very, very careful. And that's why I usually use a cannula, which is a blunt tip and opening is at the side. So the chance of vascular complication is not there.
Ma'am, where do you inject from? Is it in the socket? If in cases of anophthalmic socket, is it inside or do you do a transcutaneous?
So what I do, you need to pierce the orbital septum and then you need to go intracorneal, but it should not be more than 0.5 cc, because we all know that 1.1, like every volume enhances, so it has an absorption of water capacity of up to 1,000 times, right? So it should be very minimal. On the table, always under correction 0.4 to 0.5, but within 2 weeks time, you can see the good volume that it has given. Initially I started in non-seeing eye, like those patients done where we have done an enucleation bond implant many years back, and now we can see some deep superior sulcus, some amount of, loss of volume. There, since it's a non-seeing, I used to do 4 point. Okay, but if it is seeing eye, it is always 2 point. One is inferior median and the other is inferior lateral. But you should be very careful and only with cannula, not with needle in a seeing eye. We have done a couple of cases, around 10 or 12, and we are planning to publish it. But I feel for seeing never more than 0.4 or 0.5 cc, and non-seeing you can go for 1 cc.
And ma'am, have you had to repeat injections like in a year or 2? Do you think that the effect reduces over a period of time?
It's interesting, though the company people many times says it stays for 18 months to 18 months max, but we have seen result it stays for more than 2 years. When I think many of you doing for the tear trap, I have patients where for the 5 years, it's staying there and she's so happy without any repetition. I feel the penetration, it depends how it penetrates the tissue. If you use as a bolus with a needle, then the chance of getting, washed away is faster. But anything you do with a cannula and go for tissue penetration, that is what Dr. Goldberg's video has shown. Have you seen when he was showing the movement, you could see those black spots in the orbicular spleen. That is, it has penetrated. So those which penetrates, and he also mentioned it stayed for pretty long time. So it depends upon how the tissue penetrates. And I prefer either no financial interest, but either Juvidum product or Restylane product. I have not used any other products.
Right.
So I feel tissue penetration is an important factor in retaining the, the product.
We'll be looking forward to that paper, ma'am, because it sounds really interesting. And that is a very, it's a common problem that you see in ophthalmos, after years of enucleation or evisceration. So thank you so much.
Post-fracture ones also, the effects are dramatic. I can vouch for the dramatic effect that you can get in these patients, life-changing.
Right, because even in fracture patients, the amount of ophthalmos sometimes is very small. So, doing surgery and the amount of scar tissue that you're going to create with the surgery. So you can't really titrate as well as you can with filler. I think the most, I would say the most advantageous thing about using fillers is that you can really titrate the amount of effect you're going to get with it, which is not possible with surgery. So, yeah.
So thank you for that wonderful presentation and a great discussion which we had about the fillers and neurotoxins. Now, I would like to invite our next speaker, Dr. Richard Allen. He is Professor Oculoplasty at Baylor College of Medicine, Texas Children's Hospital, and he has edited and narrated over 300 oculoplastic surgery videos. And I think every oculoplastic surgeon who is going to operate for the first or second time sees his videos before going to the OR. He has several publications, and today he'll be discussing about the PD-1 inhibitors' role in eyelid and orbital malignancies.
All right. Thank you so much for inviting me to participate. Really, really appreciate it. Look forward to hopefully seeing some of you next week in Malaysia. Let me see if I can share my slide and hopefully you all can see it. Okay, great. So I just want to talk a little bit about PD-1 inhibitors and some of the lessons that I've had lately or learned lately from them. I have no financial disclosures. As you know, targeted agents are really sort of the future of oncology and rheumatology treatments. The idea more than anything else is to target specific molecules for tumor growth to get more precision with fewer side effects. This can be applied to orbital, eyelid, lacrimal disease, oncologic, as well as inflammatory conditions. When we think about traditional treatment of orbital malignancy, this has usually been surgical excision, at least having a component of that in our treatment. However, this can be disfiguring, and sometimes it can be incomplete. And if it's incomplete, it's really not an oncologic surgery. We can always apply radiation. However, this can also affect adjacent structures, especially the eye. And then we can always use traditional chemotherapy, but the problem with traditional chemotherapy is that it is relatively nonspecific and affects the normal populations of cells. So any cells with a high mitotic rate, and therefore you're going to get side effects from that. When we think about molecularly targeted agents, just generally, we usually split this into either monoclonal antibodies or small molecule inhibitors. You can always tell from the name which is which, because if it's a monoclonal antibody, it's going to end in MAB. If the small molecule inhibitor, it's going to end in IV. When we think about monoclonal antibodies, really the way these work is that they target specific antigens. This is always intravenous or subcutaneous therapy. It can sometimes be intralesional, usually going to target transmembrane receptors, extracellular growth factors. When we think about how this works, basically it's going to be an antibody to a specific marker on the cell. So either block a receptor and disable the signaling pathway, or potentially we can use it as an immune response to the antibody antigen complex, which results in death of the cell. However, lately, the big thing in oncology is to use these to block a checkpoint in the immune system, and that's what we're going to talk a little bit about today. Small molecules are usually oral therapy. They're small molecules, so they penetrate the cell membrane, and usually they're going to interfere with a metabolic or enzymatic step within the target cell. So it's sort of easy to think about those two. Monoclonal antibodies, you're going to give them intravenously or subcutaneously. They're not going to get inside the cell, whereas with small molecule inhibitors, they're small molecules. They can be given orally, and they're going to be able to get into the cell. However, we're going to talk about a little about immunotherapy this evening, and these two guys actually won the Nobel Prize for this. Checkpoint inhibitors really take advantage of the host's immune system to fight abnormal cells. And I think the easiest way for us to think about this is, when we think about our worst cancer patients, they're usually immunosuppressed. When I think about some of my worst cancer patients, these are usually patients that are immunosuppressed, especially patients with squamous cell carcinomas of the skin, cutaneous squamous cell carcinomas. We need a healthy immune system to prevent development of neoplasms. So when I have that patient that has a solid organ transplant or a history of CLL, these usually develop the worst cutaneous non-melanoma skin cancers. However, some of these tumors overexpress immune checkpoint molecules. And so there's really two pathways that are now targeted with regards to immunotherapy: the cytotoxic T lymphocyte associated antigen 4 pathway, which is CTLA4, and then you have programmed cell death, so PD1, PDL1, basically. So the way anti-CTLA4 antibodies work is really CTLA4 is expressed on cytotoxic T cells and regulates and inhibits T cell activation. So by blocking this is going to enhance T cell response. So basically, you are just trying to jazz up the immune system. And this can have some untoward results also, because essentially you're placing this patient's immune system in overdrive. And so they can also have some autoimmune issues, and we'll talk a little bit about that. So you're sort of giving them an autoimmune disease when you sort of think about it. PD1 inhibitors, basically limits the activities of PD1 limits the activity of T cells. So by binding this, it basically allows these T cells to reactivate. And so you can block either PD1 or PDL1 or potentially PDL2. And this has really been used a lot in metastatic melanoma and lung cancer. So how are we using these in eyelid and orbital oncology? Well, cutaneous squamous cell carcinoma has really, the treatment of cutaneous squamous cell carcinoma for me has really changed with the use of PD1 inhibitors. Conjunctival squamous cell carcinoma, I don't take a lot of care of a lot of squamous cell carcinoma, but this has also been reported to be successful. And, sebaceous carcinoma, some varied results, but what we do know is that PD-1 is expressed in some of the sebaceous carcinomas. There have been anecdotal reports of, some tremendous responses to PD-1 inhibitors, but right now it's not really used a lot. Basal cell carcinoma, some reports with regards to its use. There was some initial excitement about the potential of using these at lacrimal gland carcinoma. However, it really hasn't panned out. And then Merkel cell carcinoma does, some of these do express PD-1. So it has been used in Merkel cell carcinoma. However, this is just from JAMA Dermatology 2017, basically showing a patient with squamous cell carcinoma then being treated with pembrolizumab, PD-1 inhibitor. And this is just purely with treatment with immunotherapy, no surgery or anything like that. Pretty amazing. What I see, the biggest effect it's had for me is in the treatment of patients with perineural spread of their squamous cell carcinoma. So here's a patient who has a history of a lower lid squamous cell carcinoma, now with perineural extension along their infraorbital nerve. In the old days, you didn't have very good treatment. Maybe you would consider exoneration, but in general, we believe that exoneration probably doesn't really help all that much. It might control the local disease, but then you're going to give them radiation afterwards, and potentially they're going to have intracranial extension. Now, here's a patient that I saw just about a year ago who came in. He had actually lost his eye on the right eye due to perineural extension of his squamous cell carcinoma. His eye was eviscerated due to the fact that he had had a neurotrophic cornea and basically had perfed his eye due to that. He has extension along the supraorbital nerve, and here he is after treatment with a PD-1 inhibitor. And here's his axial view. Again, you can see he's lost his eye. He has extensive perineural invasion, even into his cavernous sinus. Here he is just after treatment with the PD-1 inhibitor, and essentially no evidence of disease. So really pretty amazing results when I've seen some of these patients. Here's another patient that I saw with perineural extension along her infraorbital nerve. Here she is just, purely just after treatment with immunotherapy, no evidence of disease. So pretty amazing results, something that I never thought I would have seen, probably 15 years ago. These were very difficult patients to treat because you basically had a surgical approach to them followed by radiation, and usually that surgical approach was going to involve exoneration. Here's a patient with a Merkel cell. So here's one of my patients came in with a Merkel cell, pretty extensive Merkel cell here, sent to the, I always get the medical oncologists involved as well as my head and neck surgeons involved because these patients will need a sentinel lymph node biopsy. And here, and the medical oncologist said, let's try PD-1 inhibitor. Okay. Now there's this question about progression versus pseudoprogression. So part of the problem is that when you put these patients on immunotherapy, they may have an inflammatory response to the tumor, which may make it look larger. And the question is this true progression or is this pseudoprogression? Pseudoprogression meaning that it's just an inflammatory response that we're seeing rather than progression. Well, this is what he looked like, about a month later, and this is true progression. This was not pseudoprogression. So this is one of my Merkel cell patients who did not respond to PD-1 inhibition. But early on, it was sort of, it was sort of confusing because early on we saw some growth to the tumor, and we were trying to figure out whether this was pseudoprogression or whether this was true progression. But in the end, this was true progression. Unfortunately, this patient actually died from his disease. Now, since we are sort of placing your immune system in overdrive, you can get a lot of adverse events or side effects from checkpoint inhibitors. Again, the way I sort of think about it is that you're just giving these patients an autoimmune disease, and you're hoping that that autoimmune disease just attacks the tumor, but it can also cause some other problems with regards to the patients. And a lot of patients will have to stop these medications due to the adverse events. So what do we see with regards to ocular side effects? Orbital inflammatory disease, we see uveitis, scleritis. There's reports of induction of thyroid orbitopathy, even with the development of hyperthyroidism. I've seen a lot of lacrimal gland inflammation associated with immunotherapy, myasthenia gravis, scoliosis, even some in ophthalmos. So I'm just going to show you a patient here, 69-year-old who has a history of metastatic prostate adenocarcinoma, and he notes acute painless ptosis on the left greater than the right. Well, noted on awakening about a week ago, no other neurological deficit, no swallowing issues, no headache, scalp tenderness, jaw claudication. He has a history of metastatic castration-resistant prostate cancer. And basically, he has been placed on not just CTLA-4 inhibition, but also PD-1. So he's on basically double dose of immunotherapy targeting both pathways. And so the concern here was myasthenia or myositis or even metastasis. We imaged him, everything looked good, and it was determined that he actually had myasthenia from his immunotherapy. Here he is 8 weeks later, and here he is 8 months after presentation. But he had to stop his immunotherapy due to this, and he actually succumbed to his disease about a year later. And so even though these medications can be great, not everybody can tolerate them. Just going to show you one last case, and this is one of my patients who came in, it was about a year and a half ago, and she was referred in for recurrent squamous cell carcinoma of the left orbit and left lower lid. She had a history of a cutaneous squamous cell carcinoma that was removed, and unfortunately, she now has a recurrence. And pretty big squamous cell. You can see her motility here, and she obviously has some orbital extension here. And so, basically I discussed with her what to do. We're sort of leaning towards exoneration for her. But I sent her to the medical oncologist, and medical oncologist worked her up. And when they worked her up, they actually found that she had a lung mass. And it ended up that she had a primary carcinoma of the lung as well. She was a heavy smoker. And so she had two primaries, this squamous cell on her left lower lid, as well as this lung carcinoma. Medical oncologist said, really the lung carcinoma is more important than what you're seeing on the eyelid. They're going to treat her for that. And so they treated her with traditional chemotherapy, and her squamous cell actually responded to that. And so, it gave us some time. And I said, okay, we have a little time here. She's being treated with traditional. I was going to look up what she was given exactly, and I don't have that down. I apologize for that. But she was treated with traditional chemotherapy for her lung cancer, and her squamous cell on her eyelid and her orbit actually improved. So here it is. And then they actually started treating her with some immunotherapy for her lung cancer as well. And you can see she had a very nice response. So even better, and, doing pretty well. And now I'm starting to think, well, maybe I can resect this, or maybe I can just buy time here and, not exonerate her. And I was hoping for that. And so even on down gaze, you see last time her motility was affected, her motility is improved. However, unfortunately, she experienced some adverse effects from her immunotherapy, and she stopped her immunotherapy. And this was what she looked like 10 weeks after stopping her immunotherapy. So immunotherapy works. And, this is just a ridiculous response. When I saw her come in, I couldn't believe that she didn't call me sooner, but, big time progression after stopping her immunotherapy. And so this ended up being a surgical problem for her. And unfortunately, she was exonerated with a free flap placed. But I think, take advantage of these newer therapies in the care of your patients. I don't think they're going away. I think this really is part of the future of oncologic care. Involve your medical oncologist, and sometimes you have to involve the rheumatologist as well. I think the biggest issue with these is that they're very expensive and it probably prevent widespread use, at least in the near term. Thank you again for inviting me to participate this morning. Really, really appreciate it. Hope to see some of you next week, and happy to take any questions if there are any.
Thank you, sir, for the wonderful lecture and giving us an insight about the future of management of lid tumors and the future of use of PD-1 inhibitors. I think it might take longer time to come to India because of the cost effectiveness and acceptability by the patients. So any questions by the panelist?
Yeah, I think
Yeah,
that, the biggest issue is cost. I mean, it's
yeah.
been,
Yeah.
it needs to come down.
That's what my question was going to be, Richard. How are you? Look forward to seeing you next week. How much is the cost factor? I mean, like teprotumumab, we are not able to use. It's prohibitive.
Right.
So what
I
about
agree.
these newer biologics for malignancy?
They're very similar on the order of teprotumumab, $100,000 to $200,000.
Nice.
And part of the issue is that we don't know how long to use them. Right now, a lot of these patients are sort of placed on them. We don't have enough data at this point to know exactly, how long they need to be placed. Very similar to like vismodegib. When vismodegib came out, we sort of never really figured out how long. We still don't know how long to use vismodegib, and I think a lot of it use it now just to shrink the tumor, then potentially resect. But to get cure, I don't know if we have that yet. And so a lot of it is, they end up getting immunotherapy. They're usually giving it about every 3 weeks. They'll give it for, a few cycles, see how they do. And then the question always is how durable is the result? And so I think these are things that are to be worked out with time. But I agree with you. I mean, the cost is prohibitive. Teprotumumab here, I mean, the cost is prohibitive for us. I mean, it's, even though I have a lot of colleagues who use it a lot, I use it very sparingly due to the cost. And I just think it's irresponsible to use it in patients that don't really need it. But, for immunotherapy, I think for some of these patients, it really is, I don't want to use the word miracle because I don't think that's appropriate, but I think some of the results are miraculous in the sense that, these are patients that I thought even 5 to 10 years ago, I would have been talking to them about a disfiguring surgery, and now I don't have to do that.
Does the insurance reimburse any of this?
For immunotherapy, they do. Yes. And teprotumumab is also reimbursed, but they're getting more strict.
Yeah.
Understandably.
Yeah. Thank you.
All right. Thanks so much. Thank you all for inviting me. I hope to see some of you next week.
Thank you. Wonderful meeting you.
Thanks.
So now, shall we go to the next talk? So our next talk is by Dr. Usha Kim, who heads the Department of Orbit Oculoplasty and Ocular Oncology at Arvind Eye Hospitals. She started the Ring of Hope initiative in 2004 to raise funds for the treatment of eye cancer. And in addition to the core clinical work, she has been involved in the leadership positions at Arvind Eye Care Hospital. She has multiple publications and several awards to her credit. Over to you, ma'am, for your presentation on management of difficult situations in ptosis management.
You see the screen, Dr. Gunjan?
Yes, ma'am, it's visible and it's in PowerPoint mode.
Yeah. Thank you so much for including me. Thanks to Dr. Namrata as well for putting together such a nice session. And I think after Dr. Goldberg's and Dr. Allen's talk, it's going to be a little difficult for me to talk about a very basic subject, but I think it's the bread and butter for oculoplastic surgeons. And I'm also not going to talk about simple cases. It's going to be difficult situations in ptosis surgery. So, as you all know, these surgical options in ptosis depends largely on the amount of ptosis, the levator action, and the associated comorbidities, which I'll be talking about today. Now, as you all know, we have a congenital ptosis, which could be just simple, or it could be associated with superior rectus weakness, blepharophimosis syndrome, synkinetic ptosis, that is the Marcus-Gunn-Jauregg syndrome, or the misdirected third nerve. Now, for blepharophimosis syndrome, we normally do a viviplasty to address the epicanthal fold, a frontalis sling to address the ptosis, and to address the telecanthus, we do the transnasal wiring, about which I'm sure Dr. Robersa is going to be talking about. So I'm not going to show the videos, but please remember that these patients can also have an associated, especially the females, we need to do a genetic study to rule out ovarian failure. This has to be borne in mind. These are some of the pre and post-op pictures. Now let's look at a situation where you have a congenital third nerve palsy. Please remember that these palsies, you need to, if it occurs later in life, you need to wait for at least 6 months for it to regenerate, or you'll have to correct the vertical squint before we attempt or advocate any surgical procedure. In this particular scenario, I've chosen to do a levator resection. And please remember, this is a patient who has a restriction of elevation. So you need not actually correct exactly similar to the other eye. So here the levator is being measured, the amount of resection that needs to be done is measured, and we fix it to the tarsal plate and apply the sutures. Now again here, we've not done a perfect correction, but we've tried to correct it in such a way that it doesn't compromise the cornea. So it's not a perfect correction here, but then you need to elevate the lid in such a way that the pupil is exposed and the visual axis is clear. Now, this is another situation where you have a jaw winking phenomenon. As you can see in this particular person, as he moves, rocks the jaw side to side, he has a flutter of the upper lid. It can be unilateral. Sometimes you can also have a bilateral situation, in which case you have to do a complete resection. That is, you need to do a lid crease approach, and you have to dissect out the levator aponeurosis completely and cut off the levator aponeurosis so that there's no question of reattachment of the levator. And this is done to eliminate the flutter. So you've eliminated the levator, thereby you've created a ptosis for which you can do a frontalis sling procedure. And that's what I'm trying to do now. That's the frontalis sling that I'm trying to do, following the excision of the levator aponeurosis. And once this procedure is done, you can correct it on the table. And it's not necessary that in every case of Marcus gun jaw winking, you need to do this kind of a surgical procedure. If the flutter of the lid is not too much, you can always observe. If the ptosis is not too much, you may just do a levator resection as well. So that's the surgery completed. Now you can see this is the pre-operative scenario where there is a flutter. And this is the post-operative scenario where the flutter is gone, even while rocking the jaw. But please remember, even if a few fibers are left behind, the flutter can persist and you may have to redo it. If the flutter is not too much post-operatively, you can observe, but it all depends on what the patient demands. Again, a case of neurofibroma where you debulk and you can do a frontalis sling procedure, as in this particular case. Another simple technique here I've tried to adopt is do flip the eyelid and do a tarsoconjunctival resection. And you can see here the amount of the bulky upper lid, which is corrected just by doing a tarsoconjunctival resection and debulking. So this is the post-operative picture of this particular patient. Now here is a scenario where the elevation of there is ptosis and elevation is restricted. So here you need not do a frontalis sling. Here you have a technique where you can just do a single incision and then you can do a transconjunctival approach. The advantage here in this is it's not a very extensive procedure, and here the elevation that you require for such patients is very minimal, which can be easily acquired by doing this simple procedure. And the other big advantage here is you also get an additional good lid crease, which I'll show you post-operatively. And care should be taken not to traverse through the conjunctiva. And as in any other case, you can titrate the lid height using the sleeve as your guard. And this is what you get on the table. And it's just one single incision. It's not just for the single incision, but it's also for the ease of navigation. And this is the preoperative picture, and this is the postoperative picture. This is a scenario where you have a very, very thin upper lid, and all you need to do is just find the aponeurosis and reattach the aponeurosis. Make an incision. It's very difficult in such cases because the aponeurosis might be rolled up. So you have to carefully dissect and identify the aponeurosis and bring it back to the tarsal plate and suture it. 3 sutures are required. 1 central suture. 3 is mandatory because it's always better to have 3 sutures to maintain the contour. And that's the initial suture, which actually seems like a little overcorrected. But then you can titrate it. And 1 on either side of the central suture. And then you can close the crease. And that's the postoperative appearance. Now, here, why have I overcorrected it? I'll show it in the next case. This is the patient where you normally have a canthal dehiscence in a very similar scenario like the previous patient. So I combine the two. 1, do the canthal reattachment, and then go ahead and do the ptosis correction like I did in the previous case. So here, once you do the canthal reattachment, the ptosis is going to get exaggerated. So it's better to reattach the canthus first and then go and do a ptosis correction. And this is the patient on the table. This is the correction you get. Never try to leave the canthal dehiscence. This is another scenario where you have to be extremely cautious, where you have a brow ptosis. And remember that you can never do a ptosis correction when there is a brow ptosis. So always do a brow lift before you correct the ptosis, if any. Thank you very much. I've had a very bad throat, so I'm very sober today. Thank you very much.
Thank you, ma'am, for the excellent videos. It was really a delight to see them. Any other questions? Or we can move to the next talk.
I just had one question, ma'am. That posterior incision sling that you were talking about, where you do it through the conjunctiva, have you seen cases where it affects the cornea?
Not at all. Not at all, Pallavi.
And where do you hitch it to? What layer are you trying to get the sling attached to? Because sometimes when we do like an open incision sling, then we usually suture the sling also to the underlying tissue. But in this case, we're just kind of passing it. So it stays, it holds up even though we're not really suturing it to the tissue over there.
Yes. Pallavi, number 1 question. Has it happened? Has it extruded? No, never. Now, number 2, I've been doing this procedure since I think it's almost about 15 years since I've started using the silicone slings, and it has worked wonderfully. But the choice of the cases is very, very important. And now there's a tendency for most people to switch over to silicone slings for every case. That's not what we should be doing, because everybody has started using silicone slings left and right. But I think we have to choose the cases, and in my experience, I think we've never had an issue, or we've never had an instance
It's
where
9 o'clock.
we've never had an instance where I had to suture the sling material ever. And for how do we do it? You have to flip the lid and imagine the anatomy on the reverse. You're actually brushing above the tarsal plate. You're flipping the lid and you're going through and brushing above the tarsal plate. You're not including the tarsal plate, nor are you damaging the conjunctiva. And when you make the incision on the conjunctiva, you're passing through the same site, which means it just goes in, slips in very beautifully. So it works well, and especially in cases where you have myopathies or myasthenias, where you just need to have a slight lift where your visual axis has to be clear, this actually works. And by
I think
the way,
it's minimally invasive also as compared to
Yes.
just doing an
Yeah.
open lid crease. So it's great.
Exactly. Yes. And Pallavi, you did a great job of your video. Actually, I
you,
like
ma'am.
the style in which you presented.
Thank you, ma'am. Thank you.
Yeah.
In fact, the Usha's technique, the transconjunctival sling, it's a very nice technique. I've also done a few other cases and the results are really good. Only the one thing which Usha will not like it, like nowadays, instead of sling, I have switched over all to frontalis muscle flap.
Yeah. I know Kasturi has been promoting that, but I think it's a great technique to have something autogenous, and I'm sure Dr. Grover sir will have facial latter to talk about. I think each one of us have one technique, but again, for all surgeons, for all of us, I think there's a lot to learn from each other. So it's nice to have a mix of all these things. The only advantage with that posterior approach is you get a nice crease. That's what I really like about it.
And especially when you have some fibrotic component in the interior layer, this is a wonderful technique for traumatic cases. Like if I need to give a sling for traumatic cases when the anterior lamellae are cicatrized or some fibrosis, no? If you go by this posterior approach, the results are very good. And there's never extrusion, nothing. It lives well. The anatomy is well maintained. So this is a very nice technique, what Usha has shown us.
Thank
The only comment I had was about fixation. I think I found that fixation does not give me of any kind, does not give me a very good contour. And also, if you are a little lower down than what you would like to, you start getting an entropy also. So what I found is the tissue planes are good enough to fixate any kind of sling, either the silastic one or the fascia lata. And tissue fixation, I mean, being in that plane where the tissues themselves are holding it, is a great way of doing it, because it gives you the right kind of fold, right kind of correction that you want.
Yeah, I think another point, Pallavi, is you can even do a bit of scratching on the tarsal plate to create some amount of inflammation, which is something which will automatically help in holding the parts together, I would say. So that inflammation is adequate enough to hold it. It creates a kind of a track, so it's there forever.
Thank you, ma'am.
So thank you, ma'am. And now we'll be moving to our next talk by Dr. Kasturi Bhattacharjee. She's director of Sri Shankradeva Nethralaya Guwahati and heads the Department of Ophthalmic Plastic and Reconstructive Surgery. She's reviewer of many national and international journals and has been a member editorial for American Academy of Ophthalmology INET section. She has received more than 38 prestigious awards for her work in ophthalmology and has been a past secretary in OPAI.
Yeah, can you see my slides?
Yes, ma'am. They are visible.
So thank you, Dr. Gunjan, Dr. Namrata, and AIOS for having me in this very interesting symposium on oculoplasty. So I'll be covering on advances in orbit surgery. And when I talk about advances in orbit surgery, I feel that all these advances are basically a technological advances. And one of the most important advances that we have come across is basically the navigation system, which acts as a GPS. And this gives us a roadmap to the surgery, which really really helps us during very challenging situation, where in this system we get the data. The data is in the form of the MRI, CT, or MRA, and we get the real-time updates, which can be in the form of the intraoperative landmark, the precise localization, and endpoint of the surgery. But interestingly, this software is so beautiful that it equips us with tools for differential color coding. We can go for precise marking. We can mark the site of entry, the endpoint of the surgery. We can map the site with a pathology. And one of its most important use of this system, especially in unilateral fractures or the anophthalmos, where the important thing that you can mirror it, where you can merge the normal over the abnormal. And this not only helps in identifying the defect, but the most important is that it helps in quantifying the displacement, and we can go for the customized implant. So this is what I was mentioning about mirroring, where in mirroring, you can see like this is what you see, the normal mirrored over the abnormal. So this is the case of the blowout fracture. And when we have a blowout fracture, you can see there's an expansion of the orbit. And so when you mirror the normal over the abnormal, you can see how much expansion it has occurred. And this will really help you in customizing the implant. If it is not a PSI, even the normal titanium implant that we use, you can customize it. So this is what we usually do before the surgery. We get an idea about how much of expansion it requires that needs to be corrected. Then we do the registration of the system. And once we do the registration, see, this is just before the surgery, I'm putting the navigation stylet. And as I'm putting the navigation stylet, you can see my stylet goes down into the maxilla. That means the whole of the intraorbital wall is being fractured. So you need to explore the wall. And this is a pretty big fracture that you can see with all the hematoma and many of the tissues being entrapped. And once you release it, this is what you see. And then you put the implant, and after putting the implant, like here you see that there's a gross amount of inocturnus. So you need to put a thicker implant. This is the MTV, that is the Med4, titanium Med4. So it's a 3-layered implant. Then you customize it, you design it, and you fit the implant. And after fitting the implant, you put the navigation stylet to know the endpoint of the surgery. And this is once here, this is the endpoint of the surgery. Now you put the stylet, you see it does not enter the maxilla. That is the amount of correction that you have wanted. It has guided you to go ahead with the surgery, and you can go for the educate correction. As you can see here, that fracture patient like this, where you have got so bad fractures with gross amount of inophthalmos. And this is just a post-operative correction of the same patient. And this is what you see, the implant being placed. This is how the implant has been laid. And this is the patient pre-operative. And this is few days after the procedure. And this is almost few months following the procedure, giving a very adequate correction of the inophthalmos that we see in fracture. This is another interesting case. Is a very old case of NOE, and he came to me very late with a fracture in the medial wall, the fracture in the inferior wall. And this is the same mirroring that has been done. And as you can see here, I'm putting a thicker implant here because he has a fracture both the medial wall and the inferior wall. And here, interestingly, I had to do a conjunctival DCR, which I usually do using the mucous membrane that we had to form the conduit. And then here with the same implant, I'm correcting the inferior wall fracture, I'm correcting the medial wall fracture, and then once you see the endpoint of the surgery, and you see a comparatively good correction, though it's a very old case, and it has given you an idea of, you can see the implant is a medial and the inferior wall that has been placed in, and this is a patient pre-operatively, this is a month, and this is a year following the surgery. But in situation like this, when you have the lesion in the orbital apex, where there's a tumor, trauma, or a foreign body, I feel the technological advances is really a boon. Like a situation like this, if you look to this patient, look at the axial section, you can see the case of traumatic optic neuropathy. And when you see a bone segment that is being fractured, that is the superior medial wall of the optic canal is being fractured. Look to the coronal picture out here. There's a fracture, the superior wall, the medial wall, and also the whole of the infralateral wall is being opened up. And the most important, if you look very clearly, this is what you can see, this is what you can see, a fractured segment, sorry. And let me go up to here. And this is what you'll see a fractured segment impinging on the optic nerve. So this is the situation we need to do a decompression, and the best way you need something to guide it, because you know this is such a crowded structure, it's a very dangerous structure. You have all the important blood vessels and the nerves, and this is the cylinder that I create, which gives you the site of entry and where you want to reach. And then once you load the data, this is the same patient in the axial, then you say in the coronal, you should be sure that where is the target area. then you do a registration, create an electromagnetic field, and then this stylet will guide you during the surgery. A very minimalistic procedure has been done where you go for a transcarangular incision, then make an incision on the periosteum, then you go down, and these are the anterior blood vessels and nerve. This you can easily cauterize it, but what we need to reach the canal. So you need to go more deeper. And once you keep on going deeper, you reach the posterior ethmoidal blood vessels. But here you cannot cauterize it because you have the optic canal near it. And this is once you put the stylet. You see my stylet is showing that I'm still in the posterior ethmoid. I have not reached my canal. So I need to go further down till I reach this optic canal, where you can see the beautiful annulus of zinc. You can see the optic nerve with the annulus of zinc. So what do I need to do this? I need to decompress it. And we all know when we looked at the optic canal, the orbital end. See, this is my stylet is showing I'm still in the orbital end. I need to reach so much down. And this is a virtual endoscope that you get in the system. And this virtual endoscope is also showing that I'm just at the entrance. Like as I move this endoscope, this is the superior orbital fissure you have, and just medial to it, you have the optic canal. So I have still not reached the optic canal. And we all know the most important part of the optic canal is the orbital part, because this is a narrow part. And as we go to the brain, cranial end is a much wider. So all the strangulation occurs, and this is the optic nerve that can be seen. And now you see the stylet. The stylet I can move it from the orbital end to the cranial end of the optic canal. And this is the bony segment that was impinging, which I have removed it, and I have reached the endpoint of the surgery. So you really need some guidance while doing this surgery. And this is what beautifully I want to show. Once I was doing the canal, see, I was wrong. Every time I'm putting my stylet, it is getting into the sphenoid sinus. Then I have realized that I have not reached the endpoint of the surgery. I have not decompressed the canal totally, where it is directly going to the sphenoid and not being able to enter the optic canal. So what I have done, I have further done the decompression. I remove what is possible the superior, inferior, and the lateral wall of the optic canal. And then now once I put my stylet, you can see I can move the stylet from the orbital end to the cranial end of the optic canal, which shows very well that my decompression has been complete and I can complete the surgery. And this is the patient, you can see this is a preoperative VP. This is a month postoperative VP, and see the improvement of the VP in the same patient, a beautiful improvement of the vision. And not only in this, in situation when you have a foreign body deep in the orbit, we all know when we try to manipulate this orbit of foreign body, sometimes it gets displaced. It is very difficult. So if you can draw a triangle, a cylinder, and you follow the path of the cylinder, it will really help you to go for a very minimalistic procedure without disturbing much of the tissue. And very carefully, you can remove the embedded foreign body, which is deep in the orbit in the greater wing of the sphenoid. So this is really important. But in situation like this, when you have something like a fracture involving both sides of the orbit, then the mirroring will not help. In this situation, you need to use another technology, which is the 3D print. So 3D print is also helpful in many of the cases where mirroring cannot be done, and we use the help of a preoperative 3D print, and we can plan the surgery. This is a very interesting case. Is a patient having a gross contracted socket. As you can see here, he has been moving everywhere. So what I have seen that there's a loss of bone, there's a loss of, contracture of the socket, there's loss of volume. So I need to create both. I need to give him a good bony socket, and the whole of the bony socket is extremely contracted. So I have done a very innovative technique. What I have done, I have mobilized, I have migrated the whole of the, you can see how the right socket, how much contracted it is as compared to the left. So what I have done, which I have also initially shown in one of the patients, the same way I use it for the cruisons or anything having an abnormal socket, you need to cut the maxilla and rotate the maxilla anteriorly, and this will give you a very deep socket. And once you do that, you need to fill up the volume. So this is a patient, I had taken him up for the surgery, and then I exposed the maxilla. And here the most important, if you use something like a sonoped or something with an ultrasonic cutter, the advantage is that you don't disturb the nerves. So you can see the whole of the maxilla has been exposed. And initially I have used this ultrasonic cutter and also some amount with a drill in the saw. And then when I have cut the maxilla, you can see what I am doing it very nicely. I have freed up the anterior part of the maxilla, and these are the infraorbital blood vessels and the nerve that you can see without disturbing them. the maxilla has been rotated entirely. So once you rotate the maxilla, what happens? It will make the socket deep. So this is what I'm showing in animation. This is the part of the maxilla that has been cut through. And then you need to keep the posterior bone intact, the bone contact. Otherwise, it might lead to the necrosis of the bone. So at the two ends, you can say medial and lateral, the bones are being kept intact. And then we fix it with the titanium screw and the plate. And once this is being fixed with the titanium plate and the screw, you have made the volume in the socket. Now you need to give the volume. And the best way of giving the volume is the temporalis muscle transfer, which I do for most of my exenterated cases. So I do not leave any exenterated socket just empty. I try to fill up the volume. And this, especially if it's a case of the cancer, then sometimes I may not give volume, but most in the traumatic cases or in some other indications, I try to fill up. And this is a temporalis muscle that has been used to give the volume. So this is a patient that you can see. And after that, what I have done, once a temporalis muscle has been given, I have resutured it. And then I have given a layer of the amniotic membrane so that it gives a very nice finishing, a very good healing to this tissues. And this is a patient that you can see after the operation, and this is at least now he can wear a prosthesis, and this is how he was pre-operatively, and now you can see the post-operative much better correction. So, and another important use of technology is the patient-specific implant. And this patient-specific implant is a really helpful, like in India, we get peak implants, which has really helped us in reconstruction in those situations where you have the patient comes to you very old and you have a ZMC fracture, you have orbital wall fracture, and this is something which we call lock and key arrangement. So it fits up so well that once you fit this patient-specific implant, you can go for a very adequate correction, especially when you have something like this, the whole of the zygoma being coming out, then you put this implant and you can go for a better correction of the inophthalmos. And in thyroid eye disease, I feel the technology has really helped us. And this is, I should say, one of the surgical advances, because when we do a decompression of the thyroid eye disease, we do either a broad, that is the bone removal of orbital decompression, or we do a fraud, that is a fat removal, or a combination of both. So in situation like this, where you need to remove some of the fat, I feel the QSA is controlled ultrasonic suction aspirator. So if you use a QSA like this, you'll see how beautifully it aspirates the fat. So it becomes a very minimally invasive surgery. You can see here the fat is being aspirated, and this gives a very adequate correction. And you can go for a very beautiful correction, which you plan to remove the fat in such patient of the thyroid eye disease. Here, this is a patient of a combination of both broad, that is bone removal, and a fat removal decompression. And this is the patient, you can see quite good correction. This is another patient of only fat removal. And if you look to the video, see, I've given a very small incision, and now I put a QSA tube, and the QSA tip, once it is being placed in the fat, and then you start the machine, and slowly, you'll see it will keep on aspirating the fat. The fat will come, the fat gets aspirated. And this really helps in the correction of gross proptosis, which is usually vision threatening or cosmetic correction. And this gives a very adequate correction, as you can see here. But in the situation, I like to show this patient because this is a lady who had a very advanced her husband is a chronic smoker, not responding to any medication, sight threatening. Look at the cornea. We knew that we are not being able to save the right eye, but at least try the left eye. Then we have done the same system. I have used only the fat decompression and also had corrected a full thickness blepharotomy to correct the lid retraction. And this is a patient, however, we could save only the left and not the right eye. Another patient, chronic smoker, with the same technique using the QSA. And this is what I want to show. This is a girl, she came to me, the only child of the parent having a tumor, which is classically that you can see as a glioma. And if you see the MRI, the T1 and T2 are so classic. And the parents never wanted that I need like to lose the vision. And she had some amount of finger counting close to face. So like a normal lateral orbitotomy, I have exposed her. And once I have removed the bone and exposed the tumor, I had taken a very little piece for biopsy just to be sure, though we know that glioma is basically a clinical diagnosis. And then this is a QSA I'm using it. And this is what I have learned, that in many tumors, like in solid tumors like this, even you can save the eye, you can save some of the vision. And you can see with the QSA, I'm trying to debulk the tumor as much as possible and replace the bone, and has glued the bone and then has closed the layer in the sutures. And then once it is being done, and you can see the post-operatively, what has really made me happy, if you look at the proptosis got corrected, her vision is returned. Now she is on chemotherapy, post-operative vincristine and carboplatin. And this has really, what has really made me so happy. Look at the change before and after the surgery. And when you see the coronal, you can see even till the posterior aspect, deep in the it was only tumor. And look the other side, you can see the optic nerve, you can see much of the tumor has been released. And this is my last advance that I like to show, which I believe it's really a very true advance in the management of the socket, especially the PRF. And this PRF, which is usually a second generation fully autologous biomaterial, it has got all the growth factors, whether you call it platelet-derived growth factor, the fibroblast growth factor, the transforming, or the VEGF, or the endothelial growth factor. It also has the insulin growth factor and all the mesenchymal stem cell, along with the leukocyte and the fibroblast. It really forms a conduit. It really helps you to in the reconstruction. Like this are the PRF, like every 2 cc will give you 1 PRF like this. And since I need a bigger amount of tissue, so I have sutured the PRF. And once this PRF that you get in, and this is so nice, this is autogenous, it heals so well. And then I with the glued, I have put the PRF into the socket, which is a very badly contracted socket. And then over you put the conformer, and then you get a very adequate correction. And this is what I'm now using it as a recent advances in most of my socket correction. So I believe that the surgical advances and technological advances go hand in hand in oculoplastic facial procedure. Complex diseases can be managed in the most effective manner with precision. The chances of inadvertent medical errors or misdiagnosis decreases, and definitely it improves the patient care and outcome. Thank you very much for your patient hearing.
Thank you, ma'am, for the wonderful talk. You have always, shown something different. And last time also we had seen the beautiful cases of Cruzen's disease, which were later published also in IGO. Indeed, the 3D viewing system intraoperatively gives a better view and helps to find out the exact site where the surgeon is working. Any questions? Any from the panelists are welcome now.
That was a wonderful lecture, ma'am. I have a couple of questions. That case where you talked about the contracted socket where you had hinged the maxilla. So you just make an incision at the inferior edge and you kind of rotate it forwards. But where do you fix it to?
Yeah, you need an incision. Say, if this is my maxilla, right? You need to make an incision in the anterior plane of the maxilla. You need to make an incision in the orbit. Or okay, right. Now you have this block. You need to just rotate it anteriorly, and this the lateral and the medial bony contact you should keep. So now see, this is a socket. Some part of the maxilla has been rotated. Can you see? So this is an open space. So you just cannot leave it loose like this. You fix it with a titanium plate, and you can also manipulate. You can do a L shape, C shape. You can also like do your own way, which shape you want. I usually like fitting the L shape because it comes straight like this and fix it like this. It's a very strong fixation. And at the 2 ends, you have a bony intake. So this will prevent the necrosis. And slowly what happens? You have the bone growth, like you have the bone growth coming up and slowly it fills it up.
And ma'am, another question about CUSA that you were using. I think it's wonderful for using in fat decompressions. What is the approximate cost of the machine?
System, I have taken the bone cutter, I have used an aspirator, I have also used taken a very good coagulator, which is what is the name, I don't remember. This is a wonderful bipolar. The hole came less than 40 L, less than 40 L. You need to bargain also. Initially they'll quote you very high, but it is really useful. Now, when you use the CUSA, I have stopped using the Medtronics bone cutter. I used a Q7 to cut the bones. It becomes a simple procedure. Any fellow, any residents can do it. It is not that you need to, because it's very safe. It has become very safe. It will not injure the nerve. You can see the nerve intact. So I
think that's the biggest advantage, because most of the times with fat decompression, you're worried that the small vessels inside, it might lead to some, it can affect the optic nerve. So
the ultrasound comes at the tip, right? So it comes in the burst. So this pushes the tissue. Can you understand? So it will push the nerve and the nerves and the artery, and then whatever, solid tissues are not there, it tries to succeed. So that is the safety. So that's how it does not disturb the artery and the nerves. like in the burst of the ultrasound, the vacuum, I mean, the cavitation that is formed, the cavitation, it forces the tissue out.
Thank you, ma'am.
I'm traveling today, so I'm sorry I need to leave. And thank you, Gunjan, for accommodating me early. I need to go to the airport now. So thank you
ma'am,
very much for your patient hearing, and all the best to all of you.
Okay. So I'd like to call upon our next speaker, Dr. Gangadhar Sundar, who is a senior consultant and heads the Orbit and Oculofacial Surgery Department and at National University Hospital, Singapore. He is the regional and international expert in disorders like orbital trauma, ophthalmic oncology, eyelid disorders, and lacrimal system disorders. In addition to several scientific peer-reviewed publications, he has authored a book dedicated to orbital fractures, their management and concepts, and has co-authored a book on ocular adnexal lesions. Over to you, sir. It might be late night in Singapore now, I think.
You're not audible, sir. I think it's still
Yeah,
muted.
sorry, can you hear me now?
Yeah.
Yes.
Okay, let me get the slides up. Thank you, Dr. Gunjan, for your kind invitation. I'll try to do justice, try to match some of the great speakers that we had before, Kasturi, Dr. Allen, and Bob. I think you've chosen wonderful faculty of speakers from each of whom I have learned over the years and continue to introduce into my practice. So one of the recent innovations is what I thought I should talk about, and I think Kasturi gave a beautiful treatise to all the various innovations in orbital surgery, and this is touching base on some imaging concepts in orbitofacial surgery. We all know that orbitofacial disorders can be challenging, yet when managed very well can be very rewarding. We often learn to work in teams, and that's where the craniomaxillofacial surgeons, the head and neck surgeons, and neurosurgery teams that we work with have really enabled us to do more for our children and adults. And amongst the various innovations, right now we're even talking about virtual reality and augmented reality, is actually simple concepts of imaging that we have been overlooking for the past 10, 20, 30 years. These are my disclosures, but more importantly, I would like to acknowledge my wonderful team over here, Dr. Blanche Lim over here, my two fellows operating while we're just observing and guiding them through. And compliments to these guys, they're the ones who stimulate us to do more. So when you look at imaging in particular, we used to talk about X-rays in the past, in the pre-80s era. That's when the CT scans really came in, and that's where the various spiral CTs and multi-disc detector CTs really came in, and they were actually fan beam CTs. We moved away from 3 millimeter cuts to less than 1 millimeter cuts, the IGS protocol, and now we no longer use films, but we use DICOM data. And every once in a while for orbital trauma and other conditions, we do use MRI as well. We are starting to use more and more intraoperative and postoperative CTs as well. But if you look at these images, for example, these are the images of a fracture, for example, with a conventional multi-detector CT. And these are the images actually you're now looking at it from a cone beam CT scan. And that's what we're going to be talking about today. So what exactly is a cone beam CT? Cone beam CT is nothing but a C-arm that has always been used in orthopedic and a few other conditions as well, where we are actually measuring volume of data in one go, like a burst that comes from a emitter and capture an image. And this can be actually captured anywhere from 200 to 300, even up to 360-degree plane. And the advantage of that is it catches real time within 30 to 40 seconds, the entire panographic view of the facial skeleton, which is what we use. And we started using it from our dentists, the National University Center for Oral Health, where they have it in the clinic, where the patients, children, and adults just sit in the chair, takes 30 seconds to gather the data, and the DICOM data is what we end up using it. And it works on the concept of LRA principle, which means that radiation that is required to capture the information that we need as low as reasonably acceptable. And this volumetric data is what practically is being used in the C-arms and hybrid OTs and angio-seats. In other words, all of you are kind of exposed to this in multi-specialty hospitals where we actually have this technology. So this has really found its big way in dentistry. It has completely replaced the orthophantomogram that we used to do in the past. ENT is using it a lot nowadays. Orthopedics is using it for moving away from conventional CT to weight-bearing CTs as well. Interventional radiological procedures are being guided now by cone beam CT scan. Radiotherapy, which guided is also cone beam CT and even mammography at this point of time. And that's what we're really talking about in orbitofacial surgery. The big advantage of using cone beam CT scan is it almost is up to 90% less radiation than the conventional CT scan. You know, ionizing radiation is a bad word, and every time a CT versus MRI debate always comes about, especially in patients with germline mutations and few other conditions. We don't like ionizing radiation. These machines are very compact and very mobile. They're very inexpensive, so to speak, short image acquisition times. In fact, patients walk in and walk out without any scheduled appointment, can be added on to any C-arm technology that we have. And when you're really looking at bony pathology, you really can get whatever information you want. But there are a few limitations. That includes the details of soft tissue. But if you're looking at bony details, you're actually able to get it. And if you're going to be using radio opaque implants, you actually, again, you can use cone beam CTs to assess the postoperative positioning of these implants, whether they're well placed or not. And I'm going to share our experience with some of these in various indications. So these are some examples I'm going to be sharing about, and we've been probably using this for the past, since the COVID time, so to speak, for the past 2 to 2.5 years. So case number 1 is a patient who's got a classic inferior wall blowout fracture. You can see a conventional S-shaped curve to the floor of the orbit compared to the broken orbit as well, with herniation of the contents. This is a conventional multi-detector CT where a postoperative reconstruction has been done. You don't really see the implant, but if you look at it, that particular straight line that you see over here is actually a bioresorbable implant, which you're able to capture it, whereby we have now done a reconstruction with very low ionizing radiation to capture good postoperative correction of an orbital fracture. Likewise, another case of a panfacial fracture, and I say panfacial, by our practical classification of fractures is upper, middle, and lower facial skeleton, which has been repaired. And we thought we did a good job, but if you look at a patient had postoperative inophthalmos and realize that actually the bioresorbable implant was placed well below the posterior ledge, hence warranting or justifying a repeat surgery. And like Kasturi had mentioned, here is a patient where we started using a PSI implant. This is a true match implant that we use, where we have gone back to redo the surgery in an accurate way, used a cone beam CT scan to look at the position of the implant even intraoperatively, so that you finish the surgery confidently knowing that you've done a good job. You can even do volumetric analysis for these patients, how you have reduced the volume from 35 cc's to 31 cc's by good correction with the patient-specific implant, which is nearly comparable to the volume of the orbit on the other side itself. What are the other applications that we end up using cone beam CTs for? We use it for periorbital tumors, assessing extent and location of a postoperative orbital decompressions, assessing bony deformities in patients with challenging anophthalmic sockets, and even dacrocystography. Here's an example of a 3-4-year-old child who actually had a periorbital lesion, a classic dermoid cyst, so to speak, but we always worry whether it's an intracranial extension. This is a cone beam CT. This child goes, sits in the machine, within 30 seconds, the image is acquired, and you can see the beautiful bony depression that you see. But what it also shows is a through and through from into the orbit itself. And if you have an intracranial extension, that should be also be seen as well. So with this confidence now with the cone beam CT, again, no sedation whatsoever, child sitting in the seat for 30 seconds, we're able to plan the surgery, go ahead, excise it, as you can see over here. These are examples of patients who have a bad anophthalmic socket correction, and you wonder what's going on. Traditionally, we used to send them for CT scan and MRIs to look at what implants you have. But here you can see a 16mm implant in a patient who had a retinoblastoma enucleated by an ophthalmologist as a child, where again using low dose ionizing radiation therapy to assess not only the size of the implant but the location of the implant. Another patient who had multiple anophthalmic socket reconstructions, who said, yes, I have an implant inside, and you actually realize there's no implant inside, but just a tricycle eye inside. How about using it in patients with lacrimal drainage disorders? This is a patient who had a failed dacrocystogramnostomy, as you can see over here. And a dacrocystogram now shows that the exact location of the patency of the nasolacrimal duct or the nasolacrimal sac. And you can see where the ostium site was and nothing beyond that. So you now know that that's exactly where the obstruction is, the scar tissue is. So you can do a dedicated revision DCR without any problems at all. How about patients with thyroid eye disease? These are very common, and we all are guilty of not adequately decompressing these orbits, or sometimes we over decompress these orbits so much so that we actually tear the dura of the temporal lobe or the skull base, causing CSF leaks with complications as well. So I'm a strong believer that every time you do an orbital reconstruction or you do an orbital decompression, be the surgeon who's bold enough to do a post-operative imaging to assess how adequately you have done. And as you can see over here, the pre-operative multi-detector CT and the post-operative cone beam CT giving you the extent of decompression up to the tip of the temporal lobe of the brain. The lateral wall is removed here, the deep lateral wall is removed here, showing a good balanced decompression as planned more on the left side than the right side, giving confirmation of what you had planned earlier on itself. So we looked at our own data. We have about 25 patients so far to date, courtesy of Emmanuel Lee, our current fellow at this point of time, where we're looking at the demographics, the vast majority of men, being most of them are trauma etiology, but there are enough amount of women who have various other pathologies that we treat with. Most oftentimes we end up using it for post-operative confirmation of good decompression or good reconstruction so far. But we also use it for pre-operative situations in certain conditions itself. The vast majority of the patients, as you can see over here, again, it's all for fractures, but you do have a significant proportion of patients who use it for thyroid disease patients and bacteriology patients and a smaller group of oncological and ophthalmic patients as well. And the indication, prime indication for cone beam CT scan is mainly for post-operative confirmation. And that's similar to the post-operative refraction if you do refractive surgery, ensuring even if the patient doesn't complain that you've done a good job, and a slew of other indications as well. So when you look at cone beam CT scan as well, and you look at radiological imaging criteria from our clinicians, we are just fixated on CT scan, MRI, so on and so forth. The requirements for radiologists is very different from the requirement for the surgeons and the patients. From a radiologist perspective, they want to be accurate. They want to be very complete in the diagnosis. They really need to see all the various details if you want. But as a surgeon, as a clinician ordering these investigations, all you want is just enough medical information for you to make a diagnosis, do a treatment planning and surgery. But do we really consider what the patients really want? What patients want is not just a diagnosis and management, but I also want to reduce costs and radiation exposure so that we don't cause any antigen damage. So in summary, I think cone beam CT is something which has been there for about 20, 30 years, but only now really being reinvented in our orbitofacial surgery, where we think it either can be a complement or an alternative for diagnosis and management of not just orbital fractures, but a few other orbital facial disorders. We are moving away not just from pre-operative diagnosis alone, but including intraoperative imaging and navigation and post-operative confirmation imaging. And with modern algorithms, we may be able to reduce radiation exposure even more, avoid and minimize artifacts so that we can increase yield. So the volumetric data is also giving you a good representation of the adequate reconstruction program. Thank you very much once again, and I'd like to compliment my team who actually stimulate me to do more and more in this field of orbitofacial disorders, and compliments to all the speakers, and thanks to Dr. Ashok Grover and Dr. Andeep Bajaj of the team. AIOS.
Thank you, Ganga. Always a joy listening to you. So this cone beam CT that you use, how much is the radiation compared to a conventional CT? And do you always take digital images only, no films?
Absolutely right. Yes, it probably is now only about 10 to 15% of the ionizing radiation exposure dose compared to a conventional CT scan. And when I talk about conventional CT scan, it's not even an IGS protocol, sub-millimeter or 0.6 millimeter CT scan, even the so-called 3 millimeter scan, because the spiral CT does a continuous excision. And even the 3 millimeter cuts they were giving, actually they're acquiring all the images, only giving us 3 millimeter cuts. And that's limited by the number of films they have to print, which is the cost of the scan for the patients. Now these DICOM data being burnt as CTs, we completely eliminated the films, and we are getting the exact data that you want from most of the bone anatomy.
So you would use them for the more difficult cases of, say, multiple fractures rather than for the simpler ones?
Actually, not really. I mean, we still go to the conventional CT for most of the fractures in terms of where you're going to be planning navigation. You want to assess soft tissue, you want to look at the muscles, you want to look at the fat. But if you're going to do it for the navigation purposes alone, we all
intraoperatively particularly, yeah.
Yeah, intraoperatively, yes. When you're doing revision surgeries, you're right. Yeah, when doing PSIs and all this, the stakes are very high. You don't get a third chance to go back in. Those are situations where we do intraoperative. That's right.
Thank you.
So as there are no further questions, We'll like to move to the next speaker. Our next speaker is Professor A.K. Grover, sir. He is the chairperson and founder of Vision Eye Center, New Delhi. He's a senior consultant at Sri Gangaram Hospital. He's a prominent name in the field of ophthalmology and has been awarded Padma Shri by the President of India, which is the 4th highest civilian award, and has been awarded the fellowship of FRCS Glasgow, FICO, and MNMAS. So you may begin your talk on the management of blepharophimosis and Marcus gantosis.
Thank you. Can you see my slides?
Yes, they are visible.
Yes, sir.
Thank you. And wonderful to be a part of this symposium. Thanks for making me a part of this discussion and symposium. I'll be speaking on some of my pet subjects, which have been jaw winking ptosis and blepharophimosis syndrome, the current approach that I have. Let's first begin with jaw winking ptosis. As we know, our objectives are correction of ptosis and elimination of jaw winking, while ensuring that we create the minimum possible asymmetry. Now, the options in Marcus gantosis are huge. You have a large number of things that you could do, but we'll talk about a couple of them only. One possibility that Dr. Usha mentioned was a levator surgery alone, which is possibly only valid for those where the jaw winking is minimal, that is about 2 millimeters, which is cosmetically acceptable to the patient. Like in this case, where there is a jaw winking, there is a ptosis of about 3 millimeters, but there is a jaw winking. And we've done a levator surgery, the only drawback being the greater scleral show that you now have because the lid starts from a higher position. So scleral show is one major problem with these cases. And you sometimes would need a larger resection than you would need in a normal case. Now, when the objective is to eliminate jaw winking, when the excursion is anything more than 3 millimeters and the patient is concerned about the excursion, then you need to do a good levator disabling. And to me, excision with cutting off all insertions, all horns is a very effective way. And a frontalis sling procedure, either using silicone or fascia lata as the material of choice. Silicone for those cases who opt for a unilateral surgery, and fascia lata for those who go ahead with a bilateral surgery. So this is an example of a unilateral sling with levator excision in a jaw winking ptosis. Another example is this patient. So this is the elimination of jaw winking and correction of ptosis. As you can see here, works very well, except for the possible asymmetry in the downward gaze, which if it is acceptable to the patient, it's a good choice. But the asymmetry may be unacceptable in some cases, like in this patient, where the result in the primary position doesn't look bad at all, but the asymmetry is unacceptable. And some of the parents would insist on a better symmetry. And one of the options that has been used is the levator excision on the involved side alone with bilateral fascia lata sling surgery, as was done in this patient, where you can see a jaw winking ptosis on the right side. And this is after a unilateral levator excision with bilateral fascia lata sling surgery, which takes care of the asymmetry in downward gaze. But this habitual palsy or an undercorrection, apparent undercorrection, even though you corrected well on the table, is quite common and is possibly because of inadequate use of frontalis because of normal levator action on the opposite side. So bilateral levator excision with bilateral fascia lata sling is my choice for those cases who want a perfect symmetry and are willing to go for a bilateral surgery. And the way I do it is by a double triangle technique, modified Callahan's, where I use 4 incisions near the eyelid margin and the forehead incisions to create the double triangle, bit of injection of adrenaline to minimize bleeds. And I use a 1-inch incision in order to harvest a 4-inch fascia lata by using long scissors, doing the undermining and using the scissors to cut the top part as well by bending it, and then close this 1-inch incision. Now this strip is divided into those 4 that you saw, and we go ahead with the incision in the orbicularis and the skin. Open up the orbital septum to define the levator aponeurosis. Make sure we dissect it well from the conjunctiva and the tarsus, conjunctiva molars and tarsus, and do a good excision, cutting the horns well on either side and excising it just next to the vitrinals. We do a similar procedure on the fellow normal side, making sure again that we do a good excision. The planes are created between the 2 temporal and the 2 nasal incisions. The forehead incisions are made and pockets made with adequate dissection. And then the fascia lata is passed to complete the double triangles on the outer and the inner side. Now I find that these 4 incisions give me a better contour and correction. As you saw, we did not do any dissection on the tarsus when excising the levator muscle, which allowed us to do a fixation of the fascia lata without any need for suturing it onto the tarsus. And once we complete the double triangle, we take it to the forehead incision, bury the knots well, secure the knots with sutures, close up the wounds. A bit of skin excision is usually needed because of the shortening of the posterior lamina that takes place at the same time, and a frost suture is placed. And this has given me the most gratifying results in most cases. While eliminating jaw winking, elimination is consistently good. Over 98% cases have a very nice elimination. Now, there are these common cases which have hypotropia or with a superior rectus underaction or a double elevator palsy. Here you can see the deficit of elevation and abduction, and you do a primary squint surgery in order to improve the primary position, and you can see the improved bells and improved up and out movement, so that a bilateral levator excision with bilateral fascia lata sling can be carried out with good elimination of jaw winking. And in the literature, you have had all kinds of surgeries. We have had much better results in terms of correction of getting either good results, which are much better, good or fair results in almost 95% of the cases, fair being defined as 1.5 to 2 millimeter asymmetry, 1 less than 1 millimeter constituting a good symmetry. So bilateral levator disabling with bilateral fascia lata sling is an excellent option for patients willing for bilateral surgery in jaw winking ptosis. For unilateral surgery, levator disabling with silastic frontal sling is the first choice to me. Of course, I'll be trying the frontalis flaps now, but till then, this is the first choice. Okay, let's look at the blepharophimosis syndrome. We are all aware of this, and we know that several parts of our country have a lot of this. We are aware of the essential components where we need to tackle the bilateral severe ptosis, epicanthus, and telecanthus, besides, of course, lateral ectropion, which is often present. And in type 1, you may also have the ovarian insufficiency. Now, the surgical management is usually performed by me in 2 stages. first stage at least 3 years of age when we correct the horizontal component, and the second stage 6 months later with a correction of ptosis, where I've almost invariably used a fascia ladder because of the bilateral surgery that needs to be done. So the procedure of choice for me now is Y2V plasty. Used to do a lot of double Z plasty earlier, but realized that the scars that we're getting are better with this. So now I would do a Y2V plasty with MCT plication or transnasal wiring. This in the vast majority of cases, MCT plication only in the milder cases. So a mild telecanthus, a simple Y2V plasty can be carried out with the strengthening of the MPL, and this works pretty well. Now for the Y2B plasty, you need to do a good marking to take care of the amount of correction that you want to do based on the measurement of the IPD, and to bring the intermedial canthal distance to half of that. And after this marking, you would do either MPL tucking or a transnasal wiring. So let's look at this video briefly. So this is a patient with blepharophimosis. As you can see, it is severe. So we begin by doing nasal packing, which we would remove at the time of transnasal wiring. And then we've done the marking. Sorry about the sound. Let me see if I can silence this. Okay, so we do the marking so as to do a little overcorrection of the telecanthus part of it. And then we would do the incision to have limbs which are equal, which would then allow us to dissect the MPL. Once we have dissected and identified the MPL, we would go ahead with the dissection of the periosteum so as to expose the lacrimal fossa and carry out a removal of the bone, which would be in line with the medial canthus and which has to be large enough to accommodate some of the nasal tissue within some of the medial canthal tissue into the nasal cavity. Now, this is not something that I do always, the lateral canthoplasty, but in cases where the fissure is too small, I would do that. And it allows for an even better pulling of the medial canthus into the nasal cavity. Now, this is the way I pass the wire by railroading technique using a hypodermic needle. And you need to have a thin stainless steel wire like this one, which is about 26 gauge, and double passing of the stainless steel wire is done, and then you make a window on the opposite side as well. Now we pass a right fascia ladder needle from the opposite side through the bony window to appear on the side where we have already done the wiring, using a guard to make sure that we don't go anywhere near the globe, and then we pull the wire through onto the opposite side, where we pass the stainless steel wire again through the tissue close to the medial canthus, and then tighten it, rotate it around till it tightens enough for you to titrate and get a good correction, and make sure that you bury the stainless steel wire deep. And the kind of deep canthus that you can get in these cases is what you really like, and get a good correction so that you can go ahead with the second stage surgery. So as you can see here, you get a good deep medial canthus, and the result is much longer lasting, and you are able to then do a second stage surgery 6 months later. Milder cases are operated as a single stage procedure, as in this case, whereby to B-plasty with transnasal wiring was done with bilateral fascial ladder sling, and you can get good corrections. Now, the two-stage procedures you do as stage 1 with correction of the horizontal problem with or without lateral canthoplasty, And stage 2, you do a doses correction. Now we've done 75 cases over the years with results which have been gratifying. Of course, we know that there are limitations caused by the tissues being smaller, and you do have very good results for a child like this. So that is generally the procedure that I follow. Thank you.
Thank you very much, sir. That actually is your, classic procedure. And we've always seen that you've staged it versus what I normally would do. But I think your results are excellent. So that's a testimony. All the post-op slides are a testimony to whatever procedure that is that you're following. But I don't know. I mean, contrary to what you do, I do a single stage procedure. And I've also felt that we've had reasonably good results. The only thing I wanted to ask you is it necessary to do a transnasal wiring in all the cases?
No. As I showed, I would do it only for the severer cases. And some of the cases are really severe, and I wouldn't be very happy with the kind of depth I achieved without that, with just the medial palpebral ligament tucking. And the kind of palpebral fissure enlargement that I would get with that would again be limited. So for the milder cases, I would do a single stage procedure as I showed, and I would do just an MPL tucking. But for the severer cases, I find it a huge joy.
Difference. Yeah. And the lateral canthoplasty, that conjunctival positioning also is really helpful. And I think, yes, sir.
The only thing is you don't really enjoy the loss of beautiful acute angle that you otherwise have. You do a fixation and you would get a reasonable closure, but I would only do it if the palpebral fissure is really small. I used to do it as a standard procedure in all my cases. Now I would do it only for the very severe cases where I would want a lateral enlargement as well in order to get the palpebral fissure. I don't do it as a default procedure now.
All right, sir. That's useful. Thank you, sir. Thank you.
I have a question too. For the cases of transnasal wiring, and I know you do it in 2 stages, do you usually wait until they grow older so that the whole, what age?
So like in DCR, I would not do it before 3 years of age.
Okay. But also at 3 years, we don't wait for them to become like teenagers or something, because soft tissue and everything keeps changing. Do you think that makes a difference?
I don't think so. I think like in ptosis surgery, you don't want the child to suffer when he goes to school. And I don't think beyond 3 years of age, it's a major concern. Like we would do an external DCR 3 years onwards. So similarly, I would do this 3 years onwards.
And so one more last question. You have been using facial latta sling for all the cases of BPES also, as you had mentioned. So what is the youngest age at which you start harvesting facial latta? As
4
most
years.
of the 4 years.
4 years. That's why I would do the first stage only at about 3.5 years, and wait for 6 months for the tissues to relax enough to allow me to do a lifting vertically.
Thank you, sir, for the wonderful talk.
And we have our next speaker, Dr. Gunjan, who's been very kindly taking us through this whole process today. Dr. Gunjan Saluja is a consultant in strabismus, oculoplasty, and neuro-ophthalmology at the Bhatia Advanced Eye Center in Bhilai, Chhattisgarh. She's a colleague of mine. She's also done her MD and her senior residency from RPC AIMS, and very well published author, more than 50 publications, many awards to her credit. I'm going to hand it over to Dr. Gunjan now.
Thank you, ma'am, for that introduction. And I would like to talk about the management of sebaceous gland carcinoma, which constitutes around 0.6 to 10.2% of all the eyelid tumors. It's a highly malignant, potentially lethal tumor of lid, which has high recurrence rates and has a tendency for local spread with a mortality rate of 2 to 10%. It is on an increasing incidence, and it has now become, as reported in literature, it is one of the most common malignancy in India, which constitutes around 33%. Usually presents at around 6th to 7th decade, and periocular radiation remains a risk factor. Other associations like immunosuppression, familial retinoblastoma, HIV virus, HPV virus, and Muir-Torre syndrome remain the predisposing factor. One very important feature of the sebaceous gland carcinoma is that it can present itself in various forms, like in patients with recurrent chalazion, posterior blepharitis, superior limbic keratoconjunctivitis, or keratitis. Here in the right below, we can see the picture of a patient. He had underwent IND for chalazion at an outside center, and within 2 weeks had presented with such a fulminant mass. So it's important to rule out whether it's a chalazion or whether it's a malignancy first, based on the classic features like loss of lashes and sometimes a firm painless nodule or an indurated thickening of the lid. When you evert the lid, you can see the multinodular protruding fungating mass. Sometimes a persistent unilateral blepharoconjunctivitis can be the only clinical feature. For nasal shrinkage, because of the diffuse involvement of the palpebral conjunctiva or bulbar conjunctiva, can give rise to entropion also. And in late stages, one can have invasion of cornea and orbital tissues. Looking at the classic histopathological features, they can be either well differentiated or highly undifferentiated. The well-differentiated forms, as shown in the figure, they are foamy sebocyte-like cells with vacuolation of the cytoplasm, and where the vacuoles are usually located in the center of lobules. Poorly differentiated tumors, on the contrary, are basophilic. They are pleomorphic with prominent nucleoli and have high number of mitotic figures. Special stains used are oil red O and Sudan black. Coming to the TNM staging of sebaceous gland carcinoma, the T1 stage means if the tumor is less than 10 millimeters. The T2 stage means if the tumor is between 10 to 20 millimeters. And the T3 stage is anywhere between 20 to 30 millimeters, as we can see in the figures above. Besides this, the T1, 2, and 3 are further subdivided into A, B, and C, depending upon the invasion of the tarsal plate. Coming to the nodes N. So N0 means there is no regional lymph node metastasis. N1 means involvement of ipsilateral regional lymph node. The size should be of the lymph node is less than 3 centimeters. And N2 is involvement of the lid, involvement of the regional lymph node, which is more than 3 centimeters in its greatest dimension. And further, it can be A or B, depending upon the imaging, whether you have done an imaging or whether they are histopathologically proven. So the standard management of sebaceous gland carcinoma remains surgical excision with frozen section. However, the facility of frozen section is not available in most of the places. And in those cases, a wide local excision with 3 to 5 millimeters of surgical margins with delayed closure that should be done within 48 hours is the preferred choice. The reconstruction can be done depending upon the size of the defect. However, one important thing to remember in sebaceous gland carcinoma is that because the carcinoma originates mainly from the tarsus, sometimes dividing the interior and posterior lamella and then excising selectively the posterior lamella with a wide local excision, and then the reconstruction of the posterior lamella with mucous membrane graft remains an option. Another thing which is important besides lymphatic spread is the pagetoid spread. The tendency for pagetoid spread of sebaceous gland carcinoma has to be not taken lightly, and it has to be ruled out in all the cases. It has to be taken from 17 sites, as has been shown in the figure. If the involvement is up to 1 quadrant, then therapies like cryo can be helpful. However, if there is multifocal involvement in more than 1 quadrants, then mitomycin C drops, plaque brachytherapy, or surgical excision can be chosen. Now, lymph node involvement, preauricular lymph nodes are quite commonly involved. PET scan, being a non-invasive method, is now preferred. Sentinel lymph node biopsy should be done in all the patients who have a tumor of more than 10 millimeters, canthal involvement, anterior orbital involvement, and it helps in early diagnosis of lymphatic invasion. Lymphatic invasion, once diagnosed, should be managed either by neck dissection, radiotherapy, or adjuvant chemotherapy. The role of radiotherapy usually comes when cases of advanced cases with local regional lymph node metastasis or tumors which otherwise require more invasive procedures, tumors with canthal involvement, patients who are undergoing orbital exenteration with histopathological evidence of periosteal or bony invasion, incomplete excision, or systemic spread. Neoadjuvant chemotherapy, the indications almost remain the same. However, in my experience, neoadjuvant chemotherapy is much better option. Cisplatin and 5-fluorouracil are the drugs of choice, given in 3 cycles at 3 weekly intervals. Important thing to remember is to do an echocardiography before starting cisplatin in the cases because it's a cardiotoxic drug. Neoadjuvant chemotherapy allows local resection of the advanced tumors, and this is one of the sequential reduction in tumor size with chemotherapy in one of my patients, where the patient had presented with a large mass, the large lymph node, ipsilateral lymph node. And first, the incision biopsy was done. Once proven that it was sebaceous gland carcinoma, this was the picture after first chemotherapy, then further it reduced after second, and after third, the mass had drastically reduced and lymph node was not palpable. So according to the management algorithm, which I usually follow is, first of all, biopsy has to be done, whether excision or incision, depending upon the size of the tumor. Rule out lymph node metastasis and peritoid spread in all the cases. Now, if the tumor size is less than 10 mm, go for a wide local excision plus frozen section or a delayed closure, whatever is feasible. In T2 stage, if it is 10 to 20, again, if the lymph node is absent on PET scan, then go for wide local excision plus frozen. If the lymph node is present, then go for a neoadjuvant therapy. My preference is a chemotherapy, followed by a wide local excision. And if in T3 stage, if the lymph node is absent or present, irrespective of that, go for a neoadjuvant therapy first, so as to make your life easier while you are reconstructing, and then go for a wide local excision. Always remember, in any kind of sebaceous gland carcinoma or any lead tumor for that per se, never go behind saving the tissue. One has to get rid of the tumor cells, and that should be the main aim. Thank you.
Excellent, Gunjan. Excellent. It was a beautiful overview and very well summarized.
Thank you, ma'am. So, I would like to have inputs of the seniors.
The only thing I wanted to ask you is, do you do chemo perform, or do you do chemotherapy in all your cases? If you're, what would be your size to do an excision first, or do you do only an incisional biopsy in every case? So if that clarity is there, we can all.
So, ma'am, if the size of tumor is less than 10 millimeter, I think one can directly go for an excision biopsy with a wide local excision. And if the size of tumor is between 10 to 20 millimeters, depending upon the lymph node involvement and the size, if it is more than 15 mm, I would prefer to go for first an incision biopsy and then go do a PET scan and then plan for a chemotherapy initially. More than 20 to 30 millimeters, I will, without, irrespective of the involvement of lymph nodes, I prefer going for a neoadjuvant chemotherapy first, followed by the excision. And before starting chemotherapy in any form, one has to have incision biopsy reports.
Gunjan, any role of radical neck dissection in cases with preauricular as well as cervical lymph nodes?
Definitely, sir, they do have a role, but with the advancement of the neoadjuvant chemotherapy, I think it will become obsolete in the coming days, because definitely the lymph nodes, they reduce to drastically after chemotherapy cycles, and that can be recorded on PET scan also. And we need larger studies on neoadjuvant chemotherapy in sebaceous gland carcinoma per se. They are very good results.
So you can avoid surgical resection of the lymph nodes with after neoadjuvant chemotherapy. And what are the long-term results?
is still awaited. There are no large studies. The only one which I came across was a case series of 10 patients from LVPI, and they didn't do radical neck dissection in most of their cases. However, it was needed in a few. So we do need larger studies with large sample sizes to come to a conclusion for these type of treatment modalities.
Thank you.
Now, if there are no further questions, I think we have a video from Dr. Milind Nayak, sir. He has sent his video to Dr. Pallavi, I think.
Yeah, it's a very short talk and about just periocular rejuvenation, short and sweet, to end this wonderful session we've had. If the tech team has the video, if you can play that. If not, then I can share my screen and we can go ahead, whatever works.
You share your screen.
I think I'm gonna try and share this again. Is my screen visible to everyone?
Yes, it is.
Yeah. Hello, everyone. This is Dr.
And was the sound also audible?
Yes, it is. It was.
Naik, and it's an honor and pleasure to be a part of this AIOS International Oculoplasty Symposium. I'm going to quickly touch upon periocular aesthetic procedures, and just a quick reminder that we have only 2 cataracts per patient, but we have 4 eyelids, and around the eyelids there are several wrinkles, tags, and bags, and therefore oculoplasty is interesting. We also have refractive patients who get rid of their glasses. They are more aware of their periocular status, and therefore this lecture. So today's theme is going to be about skin tags, injectables, and blepharoplasty. Here are quick examples of eyelid margin lesions, a nevus, which was excised just by a shave biopsy. Another case of a periocular wart, which was removed, and also a skin tag pre and post. So these are very simple yet very satisfying surgeries. The prick that I'm going to talk about is periocular botulinum toxin for cosmetic indications, not only wrinkles such as the frown line, which is being injected here, but also brow contouring, horizontal forehead lines, and also to change the expression of a person. Another complex thing is pseudodermatochalasis. Here are 2 ladies who came to me for upper eyelid blepharoplasty, but what they actually have is a deflated eyebrow. And all we did was to fill the brow with a filler injection. You can see the same patient here after the filler injection and the recreation of the convex contour of the brow region. So brow filling can be done either with a filler injection, or you can also use autologous fat transfer as a part of a surgery or as a standalone procedure. You can also use fillers to fill the temple, which is another sign of aging. Hyaluronic acid injection into the tear trough is a very satisfying periocular cosmetic procedure. There is a young patient receiving the same, and the change in appearance and the freshness in their look is very evident. It lasts for up to 2 years, and the patients are very happy with the procedure as it is a clinic-based procedure. Here are some of the examples of young patients who received a filler injection in the tear trough. Also, middle-aged patients can improve their appearance. A very good training model for this is a DCR patient. Just before your surgery begins, you can actually train yourself to fill their tear troughs. Blepharoplasty can be either upper eyelid, which is skin and muscle plus minus fat excision, or a lower eyelid, which is predominantly fat management. In the upper eyelid surgery, we keep at least 20 millimeters of vertical lid height to maintain good closure of the eye. The other components of these surgeries could include fat removal, lateral orbicularis removal, canthoplasty, and so on. Lacrimal gland prolapse, if present, can be fixed in patients who have blepharoplasty. Here are some of the examples of upper eyelid blepharoplasty in a young person to create an eyelid fold, and in an older person to open up the eyes and reduce the dermatochalasis. Young patients with blepharochalasis can also receive an upper eyelid blepharoplasty. Double eyelid surgery to form a fold is a form of upper eyelid blepharoplasty, and lower eyelid surgeries are usually performed for excess lower eyelid fat, and the transconjunctival approach in the young patients is very popular. Here is another example of lower eyelid bleph treated transconjunctival. So transconjunctival blepharoplasties attract the patients because there is no external scar, the healing is very quick, and ophthalmologist is rightly poised to do this. So just to summarize, we have looked at skin tags, injectables, and blepharoplasty, and that completes my short talk on periocular aesthetic procedures. Thank you.
So I think that was it, and we can wrap up the session now. Already it's late. Thank you everyone for being a part of it.
Thank you, Gunjan. Thank you for holding it. Yeah.
Thank you, Gunjan.
And
Thank you,
Pallavi
everyone.
thank you, sir. Thank you, sir.
Thank you, Shah. Thank you, Gunjan. Thank you, Pallavi. Bye-bye.
you.
Thank you, Ganga.
Good night, everyone.
Good night.
Bye.